Hello, hello, hello. Hello, students. Hello. So, welcome to the class, and I request all of you to use only the Telegram for communication during the lecture. Yesterday, all those who are present yesterday are aware we had a very fabulous session. It was an entire revision of the whole gynecology we did with the help of MCQs, and today very fascinating session. We are starting the obstetrics. Okay, is it clear to all of you? I'll just write it. Okay, do not use this chat box during lectures. Use Telegram to use Telegram during lectures. Okay, is it clear to all of you? Ready? Good to go? Okay, so like yesterday, please feel free to ask questions, answer questions, and all of you will do very well. Let's start with the session. And we will be doing exactly like yesterday, topic wise MCQ. Yes, welcome all of you. Omeprazole, Shobna, Sadia, all of you welcome. Okay, so we are, and just all of you can just tell me whether you can see my presentation or not. Can all of you see the present? 1 second. Yeah. Okay. So yes, can all of you see the presentation? And we will be starting with the paper obstetrics. Yes. Okay, so just a quick recap and a recap. Yesterday, those who were present, all of you know, we have done the entire gynecology. There was a couple of doubts. There were a couple of doubts on the Telegram channel that also I will answer before the end of the lecture. If those who were not there, please see this video. It is very fabulous, and I have also sent the PDF. Okay, all those who wanted the PDF of the yesterday class, PDF has already been sent with all the annotations, and today is entire obstetric revision. Okay, and MCQ discussion. Is this understood to all of you? Can I get 3 thumbs up so that I can start? Okay, and before this, all of you are aware, please subscribe to the YouTube channel for very good video content, and also start following me on Insta so that you get regularly the MCQs and everything you get. Okay, so with this we begin our discussion. Yes, excellent, all of you. And please, I want, like yesterday, I want all of you to telling me the answers loudly. Okay, so let us begin with a anatomical MCQ, which is your branches of internal iliac artery include all except. Anybody with the answer? Okay, so this is anatomy, but why we should know? Yes. Okay, please understand, isme say the most important part, uterine artery is a branch of which division of internal iliac? So it's a branch of anterior division. What is the importance of this? Can anybody tell me that when we are treating PPH, we ligate the uterine vessel, and if the bleeding is not getting under control, I will ligate the internal iliac artery, but the anterior division. The answer is very good, all of you. Lifelong, you will not forget how to remember. Clap if you feel happy. IE. IE matlab kya? Inferior epigastric. IE is a branch of EI. EI matlab external iliac. Okay. Is this understood? Clap if you have learned. Okay, so IE is a branch of external iliac. Okay, infraepigastric is a branch of external iliac. Is this understood to all of you? Yes. Okay, so very simple, nothing much to discuss, but remember I branch of EI. Okay, moving on to the next MCQ. Yes, very important. The earliest USG sign of a pregnancy is? Anybody? Yes. Okay. So please understand, free fluid in the pouch of Douglas may be seen in conditions like inflammation. It could be ruptured ectopic. Free fluid also seen during ovulation. So ovulation ka one of the signs of ovulation is free fluid in POD. That's not the answer over here. Can anybody uh, can anybody tell me what is the sequence of events? BCD may, yes, very good. In BCD, gestational sac always comes first. Okay, so all of you look on the board. All of you look on the board. What is the, so this is the uterus. What is the first structure which we see? We see the gestational sac. Okay, gestational sac will appear how? So like a proper thick ecogenic ring, and it has got a good double decidual sign, which आपको radiology में भी teacher बताएंगे. Anybody, gestational sac is the first one. Anybody, what comes after gestational sac? Second structure after gestational sac, what do we get? Second thing we get is the yolk sac. Okay, inside this gestational sac you get one more circle ke andar circle. Okay, so the outer circle is the G sac and the internal circle is the yolk sac, and then yolk sac ke andar, attached to the yolk sac, after some time we see the fetal pole. Okay, and how do we, very good sin, and anybody, how do we measure the fetal pole? Okay, this is the fetal pole, you get over here like this, and fetal pole radiology MCQ, and then inside the fetal pole you get, I'll tell you the MCQ also. What do we get? We see the heartbeat, baby bolta hai zinda hu main. Okay, and fetal pole is measured in how? CRL. Very good. So see, with one MCQ we discuss 5 MCQs. Perfectly correct. Okay. Okay, so this, when we look at the transvaginal sonography, this is roughly seen at 4 weeks, 5 days. Newer machine, 1 to 2 days earlier. Yolk sac will roughly be seen at 5 weeks. All this we have discussed in our actual classes, okay? And fetal pole will be seen by 6 weeks, and the heartbeat also, okay? So the answer over here, gestational sac. Now, don't get confused. Earliest diagnosis of live pregnancy is by how in the whole world, how in the whole world can we know, Bilal? This is a trick MCQ. Okay, कि beta HCG cannot, ये question देखो क्या है. Now tell, सुनो all of you, hold on. If I change the question, and if I just put this, earliest diagnosis of pregnancy is by serum beta HCG, because serum beta HCG is positive even before missed periods. ठीक है, even before patient misses the period, even before missed periods, the beta HCG is positive. Okay, because please understand, any married lady or sexually active female will think of pregnancy only when she misses her periods. Example, 1st August, 28th August. So अगर 29, 30 August को period नहीं आया, she could be pregnant. But the beta HCG is positive even on 25th, 26th, 27th August. So the beta HCG becomes positive. Beta HCG is positive. Beta HCG is positive even before the missed periods, and therefore it is the earliest to diagnose pregnancy. But my dear student, the question is not about pregnancy, it's about live pregnancy. And live pregnancy ke liye, what do I need to do? I need to demonstrate the fetal cardiac activity. Is this clear? Inside this fetal pole you see the fetal cardiac activity that will tell you that, sir, now the baby is alive. Is this understood to all of you? And that is possible only by transvaginal. Common sense, no? Beta HCG will, it's a number. Suppose beta HCG is 3000, 4000, 5000. Will it tell you baby's heartbeat present or not? No. So because on transvaginal sonography, fetal cardiac activity by 6 weeks is what you remember. Advanced machine, even 5 weeks, 5 days. Okay, 5 weeks 5 days, but otherwise आप 6 weeks याद रखोगे. So that is the earliest, and the urine test and beta hcg, they are the earliest. Beta hcg earliest to detect pregnancy. Can I get 10 thumbs up? Then I will close. Earliest to detect pregnancy, but for live pregnancy the answer is transvaginal sonography. I need to demonstrate the fetal cardiac activity. Is this understood to all of you? So please don't make mistake. Okay, yes, moving on to the next MCQ. Moving on to the next MCQ. All are true for HCG hormone except. Okay, now doubles every 2 days. थोड़ा ऐड कर देंगे इन अ नॉर्मल intrauterine pregnancy. When a normal healthy intrauterine होता है, yes. So now tell me the answer. Okay. Uh, it has got two subunits. Yes, alpha and beta. All of us know secreted by syncytial trophoblast, and yes, all of us know the doubling time of beta HCG is 48 hours if the pregnancy is intrauterine and if it's a healthy. Very good. Excellent, all of you. Maximum levels are not seen in the third trimester. Anybody? When is the maximum level seen? 60 to 70 days. 60 to 70 days का मतलब है roughly 10 weeks, isn't it? Because 7 days make a week. So 70 days matlab 10 weeks, and 10 weeks matlab first trimester. Okay, yes. So maximum levels are seen in the first trimester and not in the third. And can anybody tell me, suppose if the HCG is not doubling, then what do I think of? If it doubles every 2 days, it's a healthy intrauterine pregnancy. Normal healthy intrauterine pregnancy. But suppose the HCG is not doubling, what do I have to keep in mind? Anybody? If the HCG is not doubling after 48 hours, which condition HCG will not double? Yes, at your level, you have to keep in mind that doubling is healthy pregnancy. If it does not double, you have to think of ectopic pregnancy. Excellent, excellent, all of you. Super. Okay, moving on. Yes, all are features of Down syndrome on ultrasonography except. Okay, so yes, all of you correct. Yes. So on Down syndrome on ultrasonography, what all do we see? Yes, sir, anencephaly is not related to Down syndrome. Anencephaly is what, sir? It is a neural tube defect. बाकी के जो feature, I'll tell you three more also. Duodenal atresia, definitely you get. What is sandal gap? I will show you. Cystic hygroma also. And inside the heart, you get echogenic intracardiac focus. All these details you don't have to remember, but inside the baby's heart, you see like this some whitish colored dots. Okay, that is called the echogenic intracardiac focus. Now tell me two more. ये तो सब rare है, ये सब rare है. This even if you don't know, okay, but what are two main features of Down syndrome on USG? What are the two main features of Down syndrome on USG, which I should know? Increase in, yes, absent nasal bone, excellent, which I have to remember, and increase in NT, yes, increase in nuchal trans. Question abhi aane wala hai. Okay, question is coming on that. Okay, so these two are the most important features of Down syndrome on USG, which we should keep in mind. Okay, yes, we'll discuss all the values and all. Okay, moving on to the next MCQ. Yes, image-based virgin. Can anybody tell me what is this picture? या बेटा आएगा, बेटा आएगा. There's a question. Don't worry, सब कुछ कवर होगा. Okay, abortion के बारे में 2-3 क्वेश्चन आपको सब समझ में आएगा. Yes. Okay. So this is what, sir? This is a sandal gap. You can clearly see this is the baby ka lower foot, and this gap which we can see there is, this is the great toe, these are the remaining toes, and this clearly gap we are seeing. So this is most likely to be seen not in all of the above. Trisomy 21 is the answer. Okay, trisomy 21 is the answer. Okay, is this understood to all of you? So sandal gap, and this is a marker for Down syndrome. The same thing जो यहाँ पे था, is sandal gap picture I have shown you. Okay, moving on to the next. Okay, now very important. 16 weeks patient has come to us at 16 weeks. पहले वो देखना है, weeks देखना है हमेशा. And there's a past history of Down syndrome. What should be best done? Very important MCQ. Okay, now please understand, when there is a past history of Down syndrome, I need to go for a confirmatory test. Is this understood to all of you? Triple marker test, which we will discuss in some time, is only a screening test. Okay, based, you only tell me. Suppose the triple marker test is normal, for sure, can you tell the patient that the baby is okay? No. And suppose triple marker test is abnormal, then anyway you will go for the confirmatory test. Okay, so please understand, any screening test, okay, any screening test जो होता है उसका कैसे होता है कि सर screening test is either low risk or high risk. If the report of the screening test is low risk, that is considered like normal. Nothing needs to be done further. But if the screening test report is high risk, then what do I do? Do I directly do MTP? No, because it is only a screening test. I have to go for the confirmatory testing. And which is the confirmatory testing in the whole world? Confirmatory testing is karyotyping. But in patients who have a past history, okay, when there is a past history, then it is always advisable to directly perform the confirmatory test, which is the answer over here. Yes. Okay, so the answer is, and color Doppler is nothing to do over here. I told you triple marker is only a screening test. And can anybody tell me at 16 weeks what is the answer? Yes, sir. Amniocentesis and karyotyping. Okay, amniocentesis and karyotyping. Is this understood to all of you? Is the confirmatory testing which should be done over here. Okay. Now, suppose if one variation, if I make the question 16 weeks into 16 weeks, if I make it into 16 weeks, if I make it into 11 weeks. Now, what is the answer? सेम एमसीक्यू, सब कुछ सेम है, खाली 16 का हमने 11 कर दिया. Yes. So please understand कि sir, amnio can only be done generally between 16 to 18 weeks or 14 to 18 weeks. So CVS is done after 10 completed weeks. So then 11 weeks, 11 to 12 का patient है या 11 to 13 weeks का patient है, please mark CVS. Clap if see how one word also. Okay, so please read the question correctly, and even if one digit changes, the whole answer will change. Okay, so patient comes to us at 11-12 weeks, CVS and karyotyping. Okay, because those are the confirmatory testing. Moving on, drop in fetal heart rate associated with placental insufficiency, which indicates placental insufficiency or fetal hypoxia, or also if the question is fetal distress. So, can anybody, where do we get early deceleration? Yes. Okay. So remember, students, there are three types of deceleration. This is on CTG. Drop matlab deceleration. Yes. Early deceleration is head compression. Variable deceleration is cord compression. Okay, and the answer over here is late deceleration. In late deceleration is indicating danger. It is telling me placental insufficiency or fetal distress. Is this understood to all of you? Okay, is it clear to all of you? Yes. Okay, now moving on to the next MCQ, which is, yes, all are part of BPP. What is BPP? Biophysical profile. Who it is also called as Manning score. Okay, Manning score. So BPP ka totally how many components? 5. You should know 5 by heart. Okay, all the 5 components by heart we should know. Scoring system, all of you know, is either 2 or 0. So 10 by 10 is a perfect score. Okay, yes. Now very good. NST होता है, fetal breathing movements होता है, fetal gross body movements होता है, and also the fetal tone. Okay, fetal tone होता है, and also क्या होता है, the liquor pockets. Okay, amniotic fluid का volume या one, basically one single pocket which is at least 2 by 2 centimeter. Okay, 2 centimeter by 2 centimeter. Okay, that is what it is. Yes, so the answer is placental maturity. Okay, placental maturity is not a part of the Manning score. Now very important MCQ in this BPP. Okay, in B, chalo, this came in the last, I have discussed it during my actual lectures also. In BPP, this fetal movements जो है, okay, in BPP, who will count the fetal movements? Who will count the fetal movements? Mother, father, intern, neighbor. And the yes. Okay. So Sindhu, please keep in mind, very common mistake is all of you other बाकी लोग correct. Okay, sir, the mother counting the fetal movement, obviously not father. और intern को और कोई काम नहीं है, intern को बहुत सारा काम है, तो intern नहीं, and not the neighbor. Why is neighbor counting the movement? Okay, so please understand this. Okay, the mother counting the fetal movement is called fetal kick count. That is different. Is it clear to all of you? Fetal kick count में mother खुद movements count करती है. In BPP specifically, the radiologist, or rightly said, the sonologist is going to count the fetal movements. Okay, is it clear? Because all these things, what I told you, okay, the fetal movements, the fetal breathing movement, this fetal tone is all done with the help of ultrasonography. Okay, on sonography screen, I see whether there are 3 movements or not, whether baby is having proper movements or not. Is this understood to all of you? So please keep in mind regarding this, that in Manning's BPP, the USG machine is required. The mother counting the fetal movement is called fetal kick count. That is separate. Okay. Yes. Now cervical ripening is because of which drug or which action of cervical? When I want to induce the labor and go for cervical ripening. So please understand this. Cervical ripening is because of PGE2, prostaglandin E2 gel. PGE2 is dinoprostone. Okay. That is to ripen the cervix and make the cervix soft and we can induce labor. PGF2 alpha के बारे में two things. It has got one and only one action. PGF2 alpha makes a strong contraction of the both upper and lower segment, and therefore I can never give when the baby is inside the mother. PGF2 alpha is used for which condition? PGF2 alpha has got one and only one role, which is for PPH. Very good, Shalini Singh. It is carboprost. And one more important MCQ which came last year. Anybody? What is the absolute contraindication for PGF2 alpha? Okay, PGF2 alpha is carboprost. Correct. PGF2 alpha, bronchial asthma. Yes. Okay. Absolute, because it will cause broncho absolute contraindication. Okay, is this understood? So all these are extremely important MCQs. Please don't make a mistake. Again, I'm so happy I teach every year. This INI-CET, methyl ergometrin contraindicated in. Methyl ergometrin under name is methergin. So methergin causes what? When in management of PPH, okay? Methyl ergometrin in the management of PPH is contraindicated in. Anybody? So methyl ergometrin, remember heart disease and hypertensive disorders. Hypertensive disorders matlab your preeclampsia, eclampsia. Okay, because it is a vasoconstrictor, it will elevate the blood pressure. Okay, so methergin should not be given in eclampsia and also in heart disease patient. Is this understood to all of you? Okay, moving on to the next MCQ. Yes, ideal time to perform the NT scan. Yes, correct. Okay, yes, half day. Very good. Okay, yes, excellent. So remember the NT scan, all of you should know, and nowadays we call it as NBNT scan. Okay, because we see for nasal bone also and nuchal translucency also, and 11 to 13 weeks. And all of us know it is a translucent space at the nape of the neck. Up to 3 millimeter is considered normal. More than 3 millimeter is a marker for Down syndrome. Okay, more than 3 millimeter marker for Down syndrome. Yes, very simple. NST is considered reactive when. Matlab NST is called normal when. What is the criteria for a reactive NST? Anybody? NST का normal criteria क्या है? Okay, so NST, all of you please pay attention. NST is done for 20 minutes. Okay, NST, all of you know, is done for 20 minutes. Okay, and in NST, we look at acceleration. And in 20 minutes, how many acceleration at least? So there should be two or more acceleration. Two or more acceleration. And again, acceleration has a criteria. This acceleration started, went up, came down. This should at least last for 15 seconds. And acceleration should also be of at least 15 beats above the baseline. Thumbs up if you remember all this. Okay, matlab ke suppose the heartbeat goes up and comes down only in 5 beats, then that is not acceleration. Okay, so now we know, do we have 3 heartbeat acceleration? No. Do I have 1 heartbeat acceleration? No. Do I have 2 heartbeat? Yes, but not in 10 minutes, because first 10 minutes you don't, then 20 minutes. Okay, so 2 heart rate accelerations are noted in 20 minutes. That is the meaning of reactive or a normal NST. Okay, now absolutely important, everything to do with double, triple, quadruple, all are screening test. पहले क्वेश्चन ध्यान से सुनेंगे. स्क्रीनिंग टेस्ट है, done in the second trimester for aneuploidy downs, except is the question. Okay, very good, excellent, all of you. Can anybody tell me why PAP A is the answer? PAP A is the answer because PAP A is a part of dual marker test. PAP A is a part of dual marker test, which very good I do in the first trimester. HCG, alpha fetoprotein inhibin is all my part of quadruple marker test. They are done in the second trimester. Very quickly, फटाफट बता देंगे. Anybody? Dual marker test में, dual marker test, HCG and PAP A. What is higher than normal? What is lower than normal? HCG higher than normal, PAP A lower than normal. Okay, triple marker test, HCG, alpha fetoprotein unconjugated estriol, ESTRIOL, HCG high and other two lower than normal. Okay, and quadruple marker test, inhibin A, no, but I'll just, this is not a clear picture. Yeah, I will just tell you. Yeah, we don't say, yeah, I'll tell you. Okay, so all these kind of questions will not come. Okay, beta, don't worry. ये सब क्वेश्चन आपको नहीं आएंगे. I will explain to you what are the signs and clearly we'll discuss that. Okay, yeah, and inhibin A, because even I cannot make. Okay, inhibin A is a part of quadruple marker. Inhibin is also higher than norm. Okay, clear. So you know, okay, PAP A is a part of we are discussing when twins आ जाएगा, so twins के chapter में करेंगे discuss. Okay, as and when we are going sequence wise MCQs. MCQs are also segregated. Okay, yes. Now something new. As per the WHO, how many visits are recommended by WHO? Okay, so old criteria में कैसा था कि WHO was recommending around 4, 5, 6 visits. Now anybody, how much? Yes. Okay, so please understand, this details not supposed to remember. but total 8 visits is what is there. That's our first trimester में एक visit हो गया. Very good. Then at around 18-20 weeks, second visit, the anomaly scan, 26 weeks for the diabetes screening, and then 30, 34, and then last में again. So totally 8 visits जो बोलते हैं minimum. Okay, so this is the, okay, yes. So WHO का yes minimum. Okay, so of course ideal is more. Okay, so 8 is the answer. 8 is as per WHO. Okay, so now yes. Now again, one more question to confuse. Screening test in the first trimester accept. All of you should get it correct. TAP A done in the first. Sir, all are done. This is first trimester. HCG first. So wrong answer, wrong question. Is it? Very good. Excellent. Okay, sir, read the question. All are screening test except. So PAP A, HCG, NT scan, all are screening test. CVS is the answer. CVS is done in the first trimester, but it is a confirmatory test. Perfectly correct. Okay, is this understood to all of you? So please don't make a mistake. Like this kind of questions are there to fool you. All of you should get it correct. Yes. Now what we discussed the BPP also. Now what is modified BPP? Modified BPP is to save time. When I do, yeah, till 13 beta, till 13 weeks, then till 13 weeks you can do. Okay, Zara? After 13, we don't do. Okay. Yeah. Yes, NST and AFI and NST. So this is just to confuse you as per the latest criteria. This is just to confuse. There's nothing like latest. AFI and NST or NST and AFI is modified BPP. It is saving time. Okay, not tone and all that. Okay, AFI is amniotic fluid index. Yes. Now identify the procedure. What is this procedure? Anybody? The procedure is that, sir, if you look at the picture, what is being done? Yes, sir. This is perisite. Okay. This is what? Sir, under ultrasonography guidance, we are poking in a needle. Obviously, exam में ये amniotic fluid को वो लोग hide कर देंगे, but you can see the needle is in the Liker pocket and we are sucking out the fluid. So this is the amniocentesis. And do I do it at 8 to 10 weeks? No. 10 to 13? No. 15 to 18, 14 to 18, 16 to 18, all that is for trisomy 21 detection. Later on, I do when there's severe poly and all that, so you can think of them. But a specifically question tha for the purpose of trisomy 21 detection, and this image question has been asked. It is amniocentesis. Okay, perfectly correct. Clap for all of you. Yes. Now, management of second stage normal labor includes all except, थोड़ा स्पेस है, ब्लैडर कैथेटराइजेशन, ब्लैडर के बाद स्पेस. ओके, सेकेंड स्टेज मतलब बेबी डिलीवरी. Okay, now anybody? So we will tell you the answer in a minute. उसके पहले one more question. What is this image? What is this image? What are we doing? Image based question. ये क्या है? This what are we doing? Image based MCQ. So this is, there's nothing like Lily's method. There's nothing like Lily's chart hota hai. Creed's method is outdated. Anybody? Burns Marshall is for what? Sir, Burns Marshall is for after coming head of the breech. Okay, you hold the baby for, so it's for the breech ka head. Okay, so this is for the after coming head of breech. That is the Burns Marshall maneuver. And yes, this, if you see, this is the umbilical cord, and we are putting the hand like this, and we are doing control cord traction. So this is done in the third stage of labor. Very good. This is the Brand Andrews maneuver is the answer. The Brand Andrews maneuver. Okay, so now all of you know the answer to this MCQ also. Okay, sir, all are done in the second stage except Brand Andrews, because Brand Andrews is control cord traction to deliver the placenta, which is done in the third stage. Is this understood to all of you? 5 thumbs up. Point number 1, the bladder should be empty because the patient is fully dilated. You can't tell the patient to go to the bathroom and do the urine, otherwise the delivery will happen in the bathroom. So bladder should be empty, both doctor and the patient. Okay, doctor's bladder should also be empty, so the doctor is relaxed. Otherwise, at the time of delivery, the doctor will go to the bathroom, who will deliver the baby. So patient's bladder should be empty. You then clean, of course, so you do this, then you clean the genitalia with betadine Savlon. Okay, भी होगा ना बेटा, bladder cleaning the genitalia होगा ना. Of course we clean the genitalia with betadine, Savlon, all the aseptic precaution. And now this is very important. What is this Ritzen maneuver? RITZEN or RITGEN. Okay, Ritzen hai, RITGEN. Okay, anybody? What is the Ritzen maneuver? Ritzen maneuver is nothing great. Okay, Ritzen maneuver is for head delivery. Keep in mind, it is nothing great. It is routinely done. Okay, it is for head delivery. Matlab what is done is, okay, yes, normal. The baby's head is flexed. The baby's head is flexed and the delivery will take place by extension. Very good. So I will gradually allow the extension to take place. Okay, so head delivery by gradual extension. Okay, so extension will take place. Extension has to take place, but I want a gradual extension. That is the Ritzen maneuver. Okay, students. So that all are done. So A, B, C, all are done in the second stage. Brand Andrews is the answer. Brand Andrews in the third stage. Okay. Now, what is, before I come to the active, ye wala, anybody, what is this? Identify the image. So here the breech is out. Okay, breech delivery hai. Breech delivery hai. Okay, you can see some forceps and the head is inside. So we are delivering what? We are delivering the after coming head of the breech. Very good. And this is a special forceps called as the Piper's forceps. Anybody? Piper's forceps after coming head of the breech. Anybody? Where is this Mac Roberts maneuver used? You don't have to remember the detail, only remember the name. Mac Roberts maneuver is done for which condition? Mac Roberts maneuver is done for shoulder dystocia. Okay, shoulder dystocia, when the head is out but the shoulder gets stuck. Hip hyperflexion onto the maternal abdomen. Okay, is this clear to all of you? Okay, so Mac Roberts and Rubens both are for shoulder dystocia. Details are not expected, only remember the name of the maneuver. Okay, now we go to this one question. 1 minute. Ye wala. Okay, yes. What is AMTSL? Active management third stage labor. Okay, so this is done to decrease blood loss and decrease PPH. Okay, AMTSL, active management, third stage labor. हाँ, so beta Wrigley's for so Wrigley's forceps is a short outlet forceps. Okay, it's a short forceps. Piper's forceps, because it has to go inside, it's a very long forceps. It has got a reverse curve. Okay, so that is the difference. So Wrigley's forceps is just a short outlet forceps, and Piper's will be very long. Okay, now पहले ध्यान से सुनो. Point number one, I have to make sure that there is no twins. Okay, why? Because if one baby is still inside, okay, this is generally क्या होता है कि at PHC and all that when sonography नहीं हुआ है and we don't know. So we need to make sure it is not that you can't do in twins. So you need to rule out twins. So A will always be first. Why? Because if there are two babies, okay, suppose there are two babies, okay, there are two babies and only one baby is out, and if I start doing AMTSL, the second baby will have distress. So I need to make sure that there are no twins. Okay, so that is I do that there should not be any twins. Then what is the most important? So then I will give 10 units oxytocin IM. So A के बाद C, and then I do very good control cord traction to deliver the placenta, and after placental delivery I do the uterine massage. Very good. Okay, so this kind of, so don't get confused when you get this kind of MCQ. तो ध्यान से सोचेंगे तो आपको easily हो जाएगा. So it is first you check for twins, then you give 10 units IM oxytocin, then you go for control cord traction to deliver the placenta, and then lastly you go for the uterine massage. So A, C, B, D. Okay, and while doing this, what could be the disadvantage? So the disadvantage is, okay, sir, the placenta has separated out. The placenta has separated out, but because I have given 10 units, both the upper segment and the lower segment will contract together. So before the placenta can come out, the cervix can get closed, and there could be what is the disadvantage of AMTSL? The blood loss will not be more, blood loss will be less. Okay, increase time interval nahi hoga, time interval will become lesser. Yes, increase incidence of retained placenta. Yes, also called as trapped placenta. Very good. Okay. Yes. Now, one minute, we did this. 1 minute. Before we go to this, पहले ये वाला. Yes. Now again, as I said, mechanism of normal labor or events in normal labor. Again, the sequence of events type. Okay. So point number, again, all this I'm going to ask you, but I have discussed this in my actual class, so all of you will know. Okay. First, what happens? The baby's head enters the pelvis. That is called as what? Engagement. So engagement happens first. Okay. So the baby's head is going to enter the pelvis. That is going to be engagement. Then what happens, all of you? I told you, if you remember, okay, sir, whatever part has to deliver will come under the pubic symphysis. Okay, will come under the pubic symphysis. So the occiput, which is over here or here, there will be a internal rotation. There will be a internal rotation. Okay, so this is the internal rotation which will happen. Then very good, the baby's head you start seeing, that is the crowning, and then the head delivery will take place by extension. After the head delivery takes place, there is a twist on the neck which will get corrected, which is the restitution, untwisting of the baby's neck. And then there is internal rotation of shoulders, which is, it is actually internal rotation of shoulders, which comes as external rotation of the head. Okay, so please, you can go and see the detailed class, but this is just in sequence. It's our first, there will be engagement, फिर there will be crowning. So 1, 4, 1, फिर 4, फिर 2 is twisting of the neck, and 3 is the external rotation. Okay, do you agree with me? Okay, 1 के बाद directly 2 नहीं होगा. Okay, this is the answer. Okay, engagement, internal rotation. Engagement के बाद internal rotation, then crowning, then head crowning के बाद head delivery. Okay, yes. Yes. Now I want the diagnosis. What is the chalo, clinical case based scenario diagnosis? Chalo, what is the diagnosis? Yes, पहले diagnosis क्या है? Okay, so point number 1, primary gravida, uterine contraction, already having 3 centimeter dilated, lower pole empty. Lower pole empty आपके दिमाग में आना चाहिए कि सर लोअर पोल नॉर्मली क्या होता है, हियर द लोअर पोल यू गेट द बेबीज हेड, isn't it? Lower pole you feel the baby head, but when we say lower pole empty, that means it is a transverse lie. That is why the lower pole is empty. Okay, and they have said lower pole empty and head on the mother ka right side. Okay, so that is also the clue, because this is the mother's right and this is right, this is left. Okay, so the head is on one side and the legs are on another side, so it is a transverse lie. Yes, and it is a transverse lie. Okay, and very good. Okay, please understand this. Okay, transverse lie, it's not IUFD है तो best is LSCS. No, Bilal. Okay, in transverse lie there is a very high risk of cord prolapse and the baby can die. So to save the baby, because moment there will be cord prolapse and the baby can die. So transverse lie we prefer LSCS because there is very high risk of cord prolapse and the baby can die. But sir, here to confuse you further, they've already given baby is dead. Okay, now please understand all this option C and D, what I have told, outdated kachra dustbin, evisceration, craniotomy, decapitation, never to be done. Okay, these are all destructive operations. I never cut the baby, baby को टुकड़ा टुकड़ा करके नहीं निकालते हैं. This is all outdated kachra dustbin. These were done 100 years back. Okay, so this IUFD is given to further confuse you. Okay, chalo, baby is dead, let me do all this. No. So, yes, I'm coming to this. Yes. Okay, so Point number one, in transverse lie, there is a very high risk of cord prolapse and the baby can die. So I do LSCS. But दूसरा most important point is that please see the pelvis is like this. Pelvis is like this and the baby is like this. Okay, so the baby is pura transverse, and remember dear students, in transverse lie there is no mechanism of labor. There is no mechanism of labor, and therefore I will do LSCS even in case if it is IUFD. Okay, is this understood to all of you? So this IUFD is just given. Yes, in other cases of IUFD we try for vaginal delivery, but in transverse lie we do LSCS. Why? Because what will happen? There is no mechanism of labor. So what will happen? Uterus will keep on contracting, 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 prolong labor, obstructed labor, rupture uterus. Okay, ECV could be done if the patient is not in labor. Here already she is in labor. There are strong uterine contraction. So when uterine contractions are there, we don't do. Is this understood to all of you? 3 centimeter. If I wait, what will happen if I wait? If you wait, there will be rupture uterus. Okay. Is this understood? Why if you wait there will be rupture uterus? Because there is no mechanism of labor. कि ट्रांसवर्स लाई में सर डिलीवरी हो ही नहीं सकता है. सो अगर ये IUFD नहीं भी है, instead of IUFD they say fetal heart rate normal 140 per minute, still the answer will only be LSCS. Is this understood to all of you? Can I get 10 thumbs up? Yes. So baby transverse lie, baby alive, all the more LSCS because very high risk of cord prolapse. Okay, transverse lie, there is a increased risk of cord prolapse, and therefore also I do LSCS. Okay, and baby dead, still I do it. Okay, and internal podalic version again we don't do because when you put the hand inside and you rotate the baby, all that, there's a risk of rupture uterus and all that. Okay. Yes, all of the following are etiology for breech except. What is the most common cause for breech presentation? Very good. Prematurity is the most common cause. Prematurity is the most common cause. Okay. Now, please understand both. If the liquor is too much, also baby keeps on rotating. So polyhydramnios, yes, the most common cause is prematurity. Very good. And if the liquor is less also, then the baby is stuck up. So oligopoly both, and the big head also prefers the fundus. If the head is very very big, then it prefers to have the fundal part in the head, and then there could be breech. Okay, so okay, so the answer is anencephaly. When it is anencephaly, generally anencephaly face presentation hota hai. Okay, anencephaly presents by face generally. Okay, anencephaly mein face presentation is more common, and ABC. Okay, ABC. Okay. Okay, so clear. So breech ka Yeah, correct, Zara. You are correct. He can come back, but then it can again come back, na? So poly mein baby keeps on rotating. So basically, it's a unstable. It keeps on changing. You are correct. It can keep on changing, but so that is the reason why there is more chance of breach. Okay. So poly also causes breach, and oligo also causes breach. Okay, keep that in mind. मतलब poly में breach, poly के वजह से breach हो सकता है? Yes, definitely yes. Okay. Anencephaly clear cut is the answer. Okay. Yes. Moving on now, difficult MCQ. Difficult MCQ. Don't get confused, but okay, okay, difficult MCQ. But now tell me only the diagnosis. Actually, answer पूरा दिया है. Don't get hassled when you get a big question. 39 weeks, labor, 10 centimeter fully dilated, pushing for now. यहाँ पे focus करो. Entrepreneurs. Chalo, chalo. What is the diagnosis? What is the diagnosis? Sub brow presentation. Okay, so very difficult virgin MCQ. Okay, very difficult virgin MCQ. Very good mortem. Okay, sir, when supraorbital ridges are felt and anterior fontanelle is felt, it is a brow presentation. And in brow presentation, there is no mechanism of labor, and patient is already fully dilated and pushing for the last 1 hour. Perform LSCS. You don't wait and encourage her to push. And ये तो सब stupidity है. How can you perform a forceps and convert to mento posture, all that? No. Okay, you don't perform internal podalic version. Okay. So बाकी के options भी एकदम stupid है. Okay. So you don't mento posture में anyway delivery नहीं होता. If at all mento posture. Okay. No, never, beta, never. Okay, never. Brow presentation forceps cannot be applied. Okay, beta, Sahil Kumar. Brow mein there is a brow mein the engaging diameter is what? Mento vertical. Brow will not enter the brow will not reach only till +2 station. Okay, Sahil. Okay, brow mein kya problem hai? The engaging diameter is mento vertical, which is 14 centimeters. Okay. So brow mein the head will not enter the pelvis only. Okay, head will be floating head. Okay, and since he's already pushing, since he's already fully dilated, yes, brow in early labor you may wait because brow can spontaneously become flexed. If it's early labor, na, the brow can change to vertex. Okay, and you don't do mento posterior because only mento anterior can deliver. Okay. No, I don't think there is any glitch from my side. I am okay. Better now? Yeah, probably some. Okay. So all okay? Yeah. Yeah. Yeah, I think it's also okay. Yeah, no issues. Okay, chalo. Okay, so clear brow, mento vertical 14 centimeter LSCS. Okay, now what is this image? This is picture A. This is picture B. From here you are converting to option A to B. This is baby is in which position? And now we are making the baby into which position? So what is the picture? What is the image? Yes, external cephalic version. Okay, external cephalic version is the no, but I've just checked my also internet speed. I'm getting almost like more than 20. This we only require around 5 Mbps. I'm getting more than 25 Mbps. Okay, so yes. Okay, yes. So this external cephalic version, very good, all of you. Yes. And what time do we do this? The best time to do the procedure, we don't do it early. Why? This is 32 to 34 considered early. What's the answer? Yes, all of you. Okay, and I don't do it in labor, and this is too late. Okay, so remember why? Because the labor can start. Basically, this is done so that we can achieve a vaginal delivery. We avoid a LSCS, and 36 weeks is the time when we do it. Okay, please understand. Many books are giving 32 to 34. It is wrong. Okay, 32 to 34 is wrong. It is to be done with 36 weeks only, because you wait, wait, because from 32, why you wait? 32, 33, 34. Yeah, maybe beta, maybe Zara, because I am having a good internet speed right now also. Okay, we'll just try to refresh and see. Okay, yeah, so 32 to 34 weeks, 32 to 34 weeks is early. You can wait, because from 34 till 36 they can spontaneously rotate. Spontaneous correction is possible. Yeah, correct. All we have. Okay. Just 1 second, I'll just refresh the browser once and let's just see. Yeah. Okay, let us see if we are. Yes, hopefully better. Let's hope for the better. Let's hope. Yeah. Chalo. Very simple. Again, all are used for after coming. Uh, okay, so very good. One more thing, that yes, if you do early and rotation, very good. Dr. Rohan also said, it's while rotating, if any problem, then we have to do early delivery. There's a risk of RDS also. So at 32 to 34 weeks, it's early, and we should therefore wait. Okay, is this clear? Yes. What is this? Yes, sir. Burns Marshall maneuver we do for after coming head. Morrissey's smelly wheat. We put the hand inside and malar. See how the maneuver done. Nobody will ask you. Malar flexion, shoulder traction, and Vigard Martin is also. Even if you don't know all na, you know clearly. Sir, Mac Roberts is for shoulder dystocia. Okay, Mac Robert is for shoulder dystocia. Okay, is this understood to all of you? Okay, so moving on. PPH associated with all except, very important MCQ, PPH. So PPH के लिए मेन क्या याद रखना है? 3 things. One is the hypertensive disorders over. Yes, anybody? Yes, very good, all of you. के hypertensive disorders में PPH over distended uterus. Can anybody give me examples of over distended uterus? So over distended uterus, like your twins, polyhydramnios, big baby, macrozomy, and that is why twins, very good. And HELP syndrome, we discussed low platelets, and HELP is a part of this. So A, B, C, all. IUGR is a small baby. Okay, IUGR is a small baby. Small baby will not have PPH. In fact, opposite of small baby, macrozomy, big baby will cause over distension and PPH. Is this understood to all of you? Okay. Is it clear to all of you? Okay, so don't make a mistake in this. Very, very simple. I want all of you to get the answer correct. PPH treated with all of the following except. So we try all the medical management first. Anybody, what is the first drug of choice? Sir, oxytocin is considered the first drug of choice. Okay, keep this in mind. Oxytocin is the first drug of choice. Methergin can also be given. Beta Sindhu, why all except pucha hai? Of course, prostaglandins we use. Which prostaglandins we use? PGE1, mesoprostol I can use, and PGF2 alpha all I can use. Okay, yes. Zara, read the question. So all except prostaglandins do I use? Yes. Can I do the packing? Yes, I told you condom, tamponade packing, and B-lin suture is the uterine compression. Yes. Why is the answer option number D? Because sir, not posterior division. Uterine artery is a branch of, yes, uterine artery is a branch of anterior division. So in case if I have to ligate the vessel, I ligate the uterine artery first and then will ligate the internal iliac anterior division and not the posterior. Is this understood to all of you? Can I get 5 thumbs up? So this is a very simple MCQ. Please don't make a mistake. Okay. Beta, really I am not able to understand. Yesterday from the place which I took is the same place where I'm taking the lecture today also. And there is what we call there is absolutely good internet speed also, and I refreshed also. Anyway, we'll take a break for 10. I will take a break in some time, and then let's hope the things become better. Okay, just give me 5-10 minutes. We'll take a break. Okay. Yes. Now, when I have a patient of previous LSCS, there is, and we are trying VBAC, vaginal birth after cesarean. What is the scar rupture rate in previous LSCS? Yes, very good. Okay, so please understand this, that on the uterus, this is the scar. Okay, we'll just take a break. Okay, this is the scar, this is the scar, and this is the scar. Okay, and the rupture rates of the scar is 0.5 to 1, 0.2 to 0.9% to be specific. Okay, so it's anyway 10:50. 10:50, we will take a break. Okay, it is 10:50. Let us take a break for 10 minutes. Hopefully the things will become better. Okay, so we take a break and we come back in. Okay. Okay, so we take a break for 10 minutes and we come back. Okay, let us hope that this will become better. Okay, yes. Hello, hello, hello. Am I visible to all? Am I audible to all? Yes, okay. So, is the audio video all clear? Is the audio video all clear? Okay, so yes, coming to this MCQ, incidence of scar rupture when we are trying a VBAC, this is called as a classical cesarean. Okay, here the rupture rate is very, very high, and this is a low vertical. Here also the rupture rate is very, very high, so we don't try VBAC over here, and VBAC is only tried for LSCS, and this scar can also rupture less than 1% is what you will remember. Okay, and therefore this 3 to 5, 4 to 5, all that is much more. Zero point 0.5 to 1 to 0.2 to 0.9 are the exact rupture rates. Okay, moving on, very important MCQ. Prerequisites for outlet forceps include all except. Yes. Okay. What is the criteria for forceps? Very good, Krisa. The membranes have to be ruptured. We should have full cervical dilatation, 10 centimeter, uterine contractions. Also, most importantly, adequate pelvis. Okay. Pelvis should be adequate. Very good, Zara, and all of you. Station cannot be 0 to plus 1. Station cannot be 0 to plus 1. The station should be at least how much? Minimum station, yes. So when we apply the forceps at station plus 2, it is called as low forceps. And outlet के लिए still further, more than and equal to plus 3, that is the outlet when the head is almost visible, plus 3, plus 4, plus 5. Okay, is this understood? But minimum station should be plus 2. Very important MCQ. Station cannot be 0 to plus 1. It should be at least plus 2. Okay, so don't make a mistake. And there's one more, two more questions. So let me see how many of you have understood this or not. One second. Huh? Yes, we come back to this in a minute. 1 minute. Huh? Yes, just the revision. Okay, we have got a multiparous patient, and after the placental delivery starts to bleed heavily. Diagnosis simple. After placental delivery, heavy bleeding. Cervix is okay, and uterus is flabby. Uterus is flabby. Chalo, what is your diagnosis? And all I use in management except. Very simple. Okay, so it's like a revision. Yes, this is very simple diagnosis. This is a tonic PPH is the diagnosis. A tonic PPH. And what is the answer? Very good, option D. मिफिप्रिस्टोन कहाँ से यूज करते हैं? I use misoprostol. Of course, yes, I use oxytocin. Anybody, what is carbetocin? New drug. Carbetocin is a new drug. It is what? It is also used in management. Carbetocin is not to kill the baby. Huh? Mifepristone is done in early pregnancy. That's what, not, you don't use the word kill the baby. Yes, mifepristone is for MTP, medical termination of pregnancy. Yes, very good. Okay, so anybody, what is carbetocin for? Sir, carbetocin is a oxytocin derivative, but is stable at room temperature. Okay, it is stable at room temp. It's a new drug. Clap if you have learned something new. Okay, so please buy it. It's a stable at room temperature. It's a new drug. Okay, it's a new drug in management of PPH. Okay, now vacuum application contraindicated in. वैक्यूम कब नहीं लगाओगे? वैक्यूम एप्लीकेशन कॉन्ट्रा इंडिकेटेड इन. Yes, very good. It's a synthetic oxytocin. Yes. So face presentation, if I apply vacuum, eyeballs will pop out. So face may never. Preterm fetus also never. Why? There's going to be increased risk of intraventricular hemorrhage. And in IUFD, it's a very, very difficult level MCQ. Sir, when there is IUFD, the pressure will not be developed properly and Chignon formation. Chignon is the artificial caput. Okay, Chignon. Chignon is the artificial caput which gets developed after the vacuum. Your pediatrics sir will show you the image also. Okay, sir, whenever there is a baby who is delivered with vacuum, you will see as a artificial caput. Okay, which will, it resolves in 1 to 2 days time. Nothing too dangerous. Okay, so this is the Chignon, and Chignon will only take place if the baby is alive. So in IUFD, what will happen is that Chignon will not take place, so vacuum will always fail. So it is the question where all of the above. So keep in mind, see, even if you know 2, D is very difficult. D, this option C is PG level. Okay, but you know कि face में नहीं लगाना है, and preterm में तो absolute contract. So preterm babies we prefer forceps because of increased risk of it. So you know कि sir A is there for sure, B is there for sure. So C होगा ही, and D is the answer. Yes, can I get 5 thumbs up? Okay, so please keep all these points in mind. Okay, now let me see longest question. बिल्कुल टेंशन मत लेना है, सिंपल है. 39 weeks, pushing for the last 3 hours, exhaustion, baby heart rate dropping down, cervix completely dilated, head visible, fetal bones. What is the most appropriate action? Perfectly correct. Now, hold on. Okay, answer आपको देंगे 2 मिनट के बाद. Now tell me this. Now, अरे सर, you have given the same MCQ. 39, 3 hours, exhaustion, heart rate, fetal bones. Yes. So can anybody tell me, sir, both MCQs are same? Both MCQs are same? Or what? Yes. Very good. Okay, sir, here the station is -3 and here the station is +3. So that is the trick, and don't get confused. And coming to the first MCQ, you will not wait and watch, because already baby heart rate is dropping down. It is fetal distress and maternal exhaustion, and it is +3. So then why do LSCS? I will go for forceps instrumental delivery. Yes, suprapubic pressure is, suprapubic pressure is for shoulder dystocia. Okay, so here the previous answer, because station is +3, we can go for outlet forceps, and forceps is even faster. But sir, since here the station is -3, I can never apply a forceps. I told you that is outdated kachra dustbin. Station ke liye minimum +2. I will not wait and watch. And the answer is delivered by LSCS. Clap if you are loving the session. Okay. OG in the chat. Is it clear to all of you? So just make sure that exam में पूरा question same होगा, but one sign is different and you will lose your marks. Okay, is it clear to all of you? So yes, perfectly. This is station -3. Forceps is not possible. Sorry. Okay, station should be at least +2. +2 for forceps. Okay, keep this in mind. Now again simple. Chalo. New style of question. Indications and prerequisite, both for either the indication or prerequisite for ventus vacuum is which of the following? 1 2 3 4 में से फिर choose करना है. Okay, so where you will apply, the question is where you will apply a vacuum, prerequisites and indication. So 4 statements are given to you. Very good. So delay in the second stage लगा सकते हैं. Definitely correct. Non-reassuring fetal heart rate मतलब fetal distress. Vertex presentation definitely. This is not correct because gestational age less than 34 weeks अगर है, this is a contraindication for vacuum. So I don't want 3, 1 2 4. 3 नहीं चाहिए, 3 नहीं चाहिए, 3 नहीं चाहिए. Yes, very good. All of you correct. Option number B is the answer. 1, 2, and 4. Is it clear? So the new style of asking question, don't get confused. 1, 2, 4, prematurity. Very good. You can't apply the vacuum. Okay, is understood to all of you? Yes. So this is how you become expert. And you imagine you had heard OBGY so many days back, you're still remembering. Okay. Yes. Now, yes, very, very important. Now, first, I only want the diagnosis. I don't want the answer. Yes. No, Shalini and Sadia, better your answer. Sindhu. Zara, no. Mortem is correct. Okay. So, dhan se suno. Zara, there's no, it's not eclampsia. Has she got convulsion? No. There is no convulsion. There is no convulsion. So, it is not eclampsia. Eclampsia nahi hai. Okay. Yes. Sir, it is BP 180, 110, albumin +4. So, it is pre-eclampsia. बट प्री एक्लाम्शिया के साथ क्या है आपको क्वेश्चन पेपर में? हेडेक, ओलिग्यूरिया, ब्लरिंग ऑफ विजन. तो क्या है ये माय डियर स्टूडेंट्स? दिस इज impending eclampsia. This becomes impending eclampsia. Okay, there is no, yeah, severe preeclampsia, agreed, but better word impending eclampsia because of that dangerous signs and symptoms. What are those 5 dangerous signs and symptoms? We have got 5 dangerous signs and symptoms. Headache, oliguria, third, fourth is epigastric pain, and fifth is nausea and vomiting. Okay, So headache, oliguria, application, and nausea, vomiting, blurring of vision. This five out of the five, the patient has already three over here. So now what will do? Next immediate line of management is next immediately what do I do? Okay, will I wait and watch? Never. Now please understand this. So we are only 34 weeks. Yes. So what? Okay. So please pay attention. Whenever there is impending eclampsia, ध्यान से सुनो. हिंदी पिक्चर में ऐसे डॉक्टर लेबर वार्ड के बाहर आता है और फेमस आइकॉनिक डायलॉग, हम माँ और बच्चे में से किसी एक को बचा सकते हैं. Okay, have you heard that movie? Have you seen that movie that either the doctor will say either I can save the mother or save the baby? No, this kind of option is not given to the relatives. When there is impending eclampsia, immediately what do I give? Magnesium sulfate. But sir, magnesium sulfate is given if there is eclampsia. Yes, magnesium sulfate is also given over here. Very important, prophylactically. Prophylactically, prophylactically, to prevent convulsion, prevent mortality. Is this understood to all of you? And then the definitive treatment is what? Delivery. Delivery is the definitive treatment. So you give max self, but then again after giving max self, you cannot wait and watch. Is it clear to all of you? I have to do the delivery because delivery is the definitive treatment. Is this understood to all of you? And the delivery has to be done when? Irrespective of weeks of gestation. That means, sir, in the question paper, let the patient be 22 weeks, 24 weeks, 26 weeks, 36 weeks. The answer will not change. No. So, Reja wrong. Wise can no. We never directly do LSCS. Okay. We never directly do LSCS. We will first give anticonvulsant, which is the magnesium sulfate. Of course, BP 180, 110. So labetalol will be given, and then this is immediately followed by induction of labor. Okay, you will always induce the labor first. If after inducing there is some fetal distress or non-progress of labor, then you can do LSCS. Okay, next the patient comes directly, you don't do LSCS. Is this understood to all of you? You will do delivery over here, and by this delivery I mean induction of labor. If induction fails, then as a last resort you can do LSCS. Is this understood to all of you? So here the answer is, and is this understood to all of you why I give Maxel prophylactically and antihypertensive labetalol? Because the question is next immediate line of treatment is this. Now similar question, I'm so happy I teach this every year, and before we proceed further, see this now. Again very similar. Now all of you tell me the answer. Okay, it's absolutely cut copy paste same. 32 weeks, BP 170, 110, albumin +2, headache, blurring of vision, but no convulsion. Best management. I want all to get it correct. Very good. If you wait and watch, you will have to go to jail. Okay, don't wait and watch. Now, start labetalol, very good, but then deliver at 37 weeks, never. Again, magnesium sulfate, very good, but then deliver at 37 weeks, no. I repeat, माँ और बच्चे में से mother is more important. 32 weeks, baby save. Very good. Baby cannot be saved. No problem. Mother is more important. Perfectly correct. Magnesium sulfate, labetalol, and induction of labor is the complete treatment. Is this understood to all of you? Take a bow. I want 10 thumbs up clap for all of you. Okay, so D is the answer over here, and the same option, the same kind of question is this also, anticonvulsant labetalol followed by induction of labor. So D followed by C. So here D first because the question is next immediate line, and D and then C. Okay, yes. Now when we give magnesium sulfate, what is the therapeutic range of magnesium sulfate to be achieved? Yes, Very good. The therapeutic range of magnesium sulfate to be achieved is 4 to 7 milli equivalents per liter. Okay. And can anybody tell me what three things do I monitor when the patient is on magnesium sulfate? What do we monitor? Beta, urine albumin is important, Namrata. I'm not saying don't look at it. Urine albumin you will see. But if the urine albumin, whether it's +1, +2, +3, +4, other symptoms are more important. Okay, Namrata, we have to look at headache, oliguria, blurring of vision, all that. Urine albumin will just tell you that yes, it's a condition is worsening. Yes. Knee jerks, very good. Knee jerks you look at. Okay, knee jerks, that is knee jerks, respiratory rate, and urine output. How much should be the urine output? Urine output should be at least 25 to 30 cc per hour. Okay, is it clear? And what is the antidote? All of you should know magnesium sulfate toxicity. तो है तो calcium gluconate. Okay. Now, before we come to this, one second. Yes. Very difficult virgin MCQ. What is the dose of magnesium sulfate? Okay, so all of you, my dear student, 14 is the answer, but 14 grams. Yes, 14 grams is the answer. So this is out. I don't give only 10. We give 14 grams. उसमें से perfectly correct. The 4 is given IV and 10 is given IM. This 10 we give 5 in each buttock. Okay, 5 in each buttock. Okay, so the answer is option number A, 14 grams, 4 gram IV, 10 gram IM. Okay, you can see this also. 4 gram is given IV and then followed by 10 gram which is IM, 5 gram in each buttock. Okay, and for maintenance then we only give 5 gram in each buttock every 4 hourly. Okay, so don't make a mistake. The CBI you need not remember. Khali ye wala. So remember 14 grams is the total dose. Grams. Okay. Now simple. If the now read. Now this is only pre-eclampsia, impending eclampsia. Yeah, and one more thing. If before I proceed further in this question, whether it is impending eclampsia or eclampsia, same answer. Eclampsia also you will immediately give magnesium sulfate and go for delivery, irrespective of the weeks. Okay, so management is the same. You don't wait and watch. Okay. Because eclampsia also immediate delivery and delivery is the definitive treatment. Now tell me the answer. Yes. So now please understand we have a patient who is having high blood pressure but no other complication. And now if the blood pressure, and she is 32 weeks. If everything is under control, You will not want to do the delivery at 37 34 weeks. You will wait, and at 37 weeks you will induce the labor and get the baby out. Is this understood to all of you? Okay. The reason being, that if you wait, why not wait after 37 weeks? Why not wait till 40 weeks? Never. And why not let the labor start on its own? No, at 37 weeks we will induce the labor. See, the labor pregnancy should be terminated by induction of labor at 37 weeks. Why not wait after 37 weeks in a case of preeclampsia? Yes, very good. Because sir, there is no point waiting. Sir, रुक के क्या मतलब है? Okay, after 37 weeks, if you wait, suddenly mother can get eclampsia, mother can get abruption, mother dead, baby dead, all that impending. Because delivery is the definitive treatment. So you are waiting till 37 weeks because for the baby lung maturity. After 37 weeks, there is no point in waiting. Is this understood to all of you? And after 37 weeks, so absolutely correct. It is risk versus benefits, what I had explained to you in the actual classes. Okay, is it clear? So till 37 weeks waiting may risk is there, but the benefits are more. After 37 weeks there is no benefit. Okay, after 37 weeks there is no point waiting. Okay, once you reach 37 weeks there is no point waiting further. Okay, no point waiting. So there is only risk. Okay, so that's better to do the delivery at 37 weeks. Okay, and earlier even if required. So the very important topic of max self, all that we should know. Very simple. Last thing, uh, what are complications? Yes, all are complications except basically what is the diagnosis? Sir, simple. It is a patient who is high blood pressure and proteinuria. So simple diagnosis preeclampsia. And can there be eclampsia? Of course, can there be help? Can there be abruption? But there would be also, if at all, IUGR. Macrozomy नहीं होता है. Okay, we get opposite of macrozomy, IUGR. So simple MCQ likely to come in the FMG exam. All of you should get it correct. Okay. Yes. Okay. So a patient who is, what is the first sign of magnesium sulfate toxicity? What is the first sign? Respiratory depression to happens towards the end. Cardiac arrest towards the end. Oliguria will not, is not the effect. Oliguria will lead to magnesium sulfate toxicity. Very good. Loss of knee jerks. Okay. Loss of knee jerks is the earliest to happen. Okay. Huh. Now, very important topics of APH, starting bleeding in third trimester. Tell me the diagnosis. 36 weeks hai painless bleeding. Which condition I get painless bleeding? With uterus relaxed and head floating. What is the diagnosis? Yes. Okay. Very good. प्लासेंटा प्रीविया ये तो नहीं है. अब्रप्शन में क्या होता है? One is it is painful bleeding. Generally the blood pressure is elevated and uterine tone, increase in the uterine tone. Okay, uterus is not relaxed. Okay, is this understood to all of you? 5 thumbs up. So sir, when there's a, and why head floating? Head floating is also very important clue, because that placenta previa will prevent the head from coming down. Okay, so this is the uterus, this is the placenta, this is the baby, this is the baby. So this placenta previa, I am writing PP, placenta previa, prevents the head from getting engaged. So that is why the head in the question paper unengaged. Head is unengaged, also called as floating. Yes, very good. Okay, so that is a clue in the question paper. Don't make a mistake. Okay. Now, next question. Chalo. First the diagnosis first. Okay. I only want the diagnosis first. Yes, excellent, all of you. We have planned now the answer. Okay, same thing. First episode, so it's a episodic bleeding, painless bleeding, and the head is floating, uterus is relaxed. Fetal heart sounds regular. Let me just add regular, matlab normal. Regular say 140 beats per minute. Okay. Now, next line of management is very good, Rohit Zara. Now, can anybody tell me why? Wait, first of all, never induction of labor. Okay, if you do induction of labor, you have to go to jail. Okay, why jail? Because, sir, if in this, if you can see, if you make the uterus contract, if you make the uterus contract by doing induction of labor, there's going to be profuse bleeding, torrential bleeding. So in placenta previa, all of us know that vaginal delivery is not possible, and whether the baby is alive or the baby is dead, the delivery is always by LSCS. But you do LSCS at a time when where you can wait, because here we are 34 weeks. Is the mother stable? Yes. Hemoglobin 11, BP 120 70, pulse भी दिया होगा regular. So mother is stable. Okay, mother stable. Baby normal, no fetal distress. Is this understood to all of you? What is this called as? So I will admit the patient, give her bed rest, give her steroids, and I will wait and watch, because we are 34 weeks, because as the pregnancy is less than 36 weeks. So इसको क्या बोलते हैं? Anybody? This expectant management, or this wait and watch in placenta previa, what it is. Here you give what? You give steroids for the baby lung maturity. You will give tocolysis. You will give complete bed. I'm writing CBR complete. Okay, so bed rest, tocolytic steroids, and close observation till you wait till 37. Very good. This is your McAfee and Johnson. Okay. Is this understood to all of you? But now trick MCQ. All of you tell me the answer. One digit change. This 34, I make it 37 weeks. Now what is the answer? All of you. Excellent, all of you. Again, you will not induce labor. And sir, once 37 weeks are, now what is the point of waiting? Okay, this minute. So now I will go for LSCS. Okay, is this labor? No, never Zara. Induction kabhi bhi nahi. Okay, never induction. Yes, yes, yes. Okay, induction matlab jail. Okay, so please, therefore, one digit is important. One digit is important. Okay, okay, sir, if it is 34 weeks, I can wait and watch. If it is 37 weeks, 37 plus weeks, agar kuch bhi hai, then we will go for LSC because now there's no point waiting. So it's please understand when you will see these are not only this 100 MCQ. With every MCQ, we are discussing 3 to 4 variations. हार्ट रेट चेंज ये वो सो ऐसा देखोगे तो 500 MCQs are being discussed okay between yesterday and today with all types of variation we are teaching you. Okay, next, so ये हो गया. हाँ, now हाँ, I want the diagnosis first. Pain in abdomen. Okay, BP elevated 150/100 and on ARM blood stained liquor. What is the diagnosis? Yes, excellent, all of you. The diagnosis is abruption. Abruption, remember the rule, never wait and watch, never give tocolysis. Okay, and besides what we have, she is only 2 centimeter dilated, and besides fetal distress, fetal heart rate 100. So it is abruption with fetal distress. So the answer is cesarean section. Yes, deliver ASAP. By chance, very, very rare. Suppose it is advanced labor. Suppose I tell you it is 8-9 centimeter dilated and fetal heart rate is normal, then you can think of oxytocin augmentation. So, but that is very rare. Here it is clearly abruption plus fetal distress. Nothing to think. It is emergency LSCS. Okay. Is it clear to all of you? Now, again, the longest question, but very simple. Yeah. So if no fetal distress, we can again, Namrata, there should be no fetal distress and there should be advanced labor. Then you can induce labor, okay? Because delivery should likely to happen soon. Here she is only 2 centimeter. So all of you from 2 centimeter to 10 centimeter is going to take 7-8 hours. Okay, so you can't wait. Suppose they tell you it is advanced labor. Okay, suppose they tell you already she is say 8 centimeter, 9 centimeter. Okay, 7 centimeter. Example. So that means she is advanced labor. Okay, plus normal fetal heart rate and already 8-9. Then you can think of oxytocin augmentation. Okay. plus no fetal distress. Is this clear to all of you? But that is very rare. That will not. That is PG level. Okay. If there's advanced labor, 8-9 centimeter, then you can think of oxytocin augmentation. Abruption plus fetal distress, nothing to think. LSCS. Okay. Yes. Now here we know we have a patient of hypertension. तो वहां पे बत्ती अलर्ट होना चाहिए. पेन हो रहा है. Now she has gone in shock. Okay. See, the patient is in shock. Why patient is in shock? Because BP down, hemoglobin down. अरे बट ऑन पीवी नो ब्लीडिंग सीन. तो कुछ तो गड़बड़ है, कुछ तो गड़बड़ है. एंड मोस्ट इंपॉर्टेंट, यूट्रस टोनिकली कॉन्ट्रैक्टेड. सो यूट्रस टोनिक, देयर इज नथिंग लाइक कंसील्ड प्लासेंटा प्रीविया. Placenta previa bleeding is always revealed. Placenta previa, the uterus is relaxed. Okay, uterus is relaxed and bleeding will always be present. Here, please read, there is no bleeding seen. So this is not revealed abruption. This is concealed. Virgin MC. Is it clear to all of you? The virgin MCQ, concealed abruption. Okay. That's sir, because the abruption has happened, but the placenta is blocking. The placenta is blocking the blood from coming out. Okay. So the baby is here, but all the blood is getting accumulated behind the placenta. Okay. So that is concealed abruption. So externally we don't see any bleeding, but the patient is going in shock. Okay. So when you don't see any bleeding, but the patient is in shock, that is dangerous. That is a concealed abruption. Okay. Diagnosis first and then next immediate line of treatment. Two months amenorrhea and pain and shock and pregnancy test positive, BP 90/60, hemoglobin 6, UPT. Anybody? What is the dictum? Shock in early pregnancy. Very good. What is our dictum? Shock in early pregnancy. Shock in the first trimester. Think first of what? Yes, it is ruptured ectopic unless proven otherwise. Okay. Shock in early pregnancy is ruptured ectopic unless proven otherwise. Now, please understand this. The question here, this is like this kind of question may or may not come. Very good. The diagnosis is ruptured ectopic. You have to think first, which is correct. Now, please understand the question is next immediate line. Okay, so obviously methotrexate to nahi hai. Methotrexate will tell you when we give. Okay. Never. Rohit and Namrata. Okay, never. Okay. This one. Okay, you must have. Okay, oh, previous answer. Yes, correct. Okay, fine. You must have given the answer for the previous MCQ. Okay. So point number 1 is ruptured ectopic. Methotrexate, I'll tell you when do we give. We give it only in unruptured ectopic. Again, laparoscopy is only done when the patient is stable. It's ruptured ectopic because patient is in shock. Okay, patient is in shock. Now, when there is next immediate line, when the patient comes to us in shock, yes, we do 2 wide bore IV lines. 2 IV lines we do. Collect blood for cross match and IV fluids is what you start. And then you don't waste time. Immediately shift the patient to operation theater. And now the definitive treatment is, anybody? Same MCQ. It's a continuation of the previous MCQ. Very good. Salpingectomy is the gold standard surgery because the tube is torn, that tube is tethered. There's no time to suture the tube. So all this salpingotomy, salpingostomy we don't do. Of course, methotrexate नहीं कर सकते. Quick in, quick out. Immediately open up the patient. Salpingectomy is considered the gold standard surgery. Okay, salpingectomy is the gold standard surgery, and that should be done as a definitive treatment. So obviously in practice everything happens together, but like this kind of question agar aata hai कि next immediately what do I do? So next immediately collect blood for cross match, IV fluids and 2 wide bore IV lens, followed by of course laparotomy and salpingectomy. Okay, so B followed by A. Okay, and in A laparotomy what do we do? Again I write salpingectomy. Okay, is this understood to all of you? And salpingectomy is the gold standard surgery. Okay, because the tube is torn. So just read the question correctly. This kind of questions are coming in NEET PG, but just to confuse you. Okay, then next immediate what do I do, and definitive what I do. It's same like same like eclampsia. Patient having eclampsia convulsion. Next immediately what do I do? Magnesium sulfate. But then definitive treatment, induction of labor and delivery. Okay, like that. Now, which condition I will do surgical management of ectopic pregnancy? That means which condition methotrexate MTX is not possible. Very good. So I come back to the answer in a minute. Uske pehle, anybody with the answer? Longest question, again the answer first. Okay, now what is the diagnosis over here? So point number 1, patient is 2 months pregnant. Okay, beta HCG is positive. Patient is stable. Okay, what is this right-sided adnexial mass of 2.5 into 3 centimeter? Yes, this is a ectopic pregnancy, and luckily we are unruptured ectopic pregnancy. How am I saying unruptured? Because patient is stable. Look at the pulse, blood pressure and hemoglobin. So I have to give methotrexate. Wait and watch, never. You're sitting on the time bomb, diffuse the bomb before exam. And repeat USG you do when it's doubtful, and you don't wait for 2 weeks. You might want to repeat after a few days also. That is only this doubtful thing. Now one more thing, anybody on you, what is this pseudo sac seen in the uterus? Pseudo sac kya hai? Pseudo sac, remember students, what is it? Okay, all of you pay attention that whenever there is a pregnancy, I told you, okay, a true sac, this is a proper G sac. Okay, this is a proper G sac. Okay, but sometimes because of the hormonal changes, we get no. That it's not an empty sac. Okay, empty. See, आपके लेवल पे ऑफ कोर्स ये वर्जिन एमसीक्यू है, either they will say that the uterus is empty. Okay, uterus empty and beta HCG positive, think of ectopic. But sometimes this pseudo sac, the name is given pseudo sac because it confuses the radiologist, it confuses the doctor, it confuses the gynecologist. It is a thin walled irregular structure. I repeat, a very, so can you see the difference? This is a proper true sac. This is a pseudo sac. Okay, it is a sign of ectopic, not empty sac. Okay, Zara, empty sac is blighted. Empty sac matlab ke sir, I see a sac, but I'm not seeing fetal pole and heartbeat and all that. That is a bad condition. That's a blighted ovum kind of thing. Okay, so we don't say empty sac. So pseudo sac and empty uterus both mean the same thing. आपके लेवल पे अगर क्वेश्चन पेपर में दिया है यूट्रस एम्प्टी, which will be given? Pseudo sac is PG level MCQ, not even SS level, super specialty level, pseudo sac. So uterus empty and pseudo sac both mean the same thing. It is basically telling you कि ये कुछ भी नहीं है, आपको यूट्रस के बाहर देखना है. It is a sign of ectopic pregnancy. Okay, is this understood to all of you? So either they will say uterus pseudo sac or they will say uterus empty. And perfectly correct. This is a sac size of only 3 centimeter, HCG level also less than 1500, and therefore methotrexate is the answer. Do you agree with me? No need to do a surgery. No need to do a surgery. Okay. And this also you know, okay, yes sir, the cutoff is 4 centimeter. The sac size is more than 4 centimeter, then we will go for surgery. Question is, what is the chance of surgical management? Okay, so anybody, what are the 4 criteria for methotrexate? When I want to give methotrexate, it should be a unruptured ectopic pregnancy. The sac size should be less than 4 centimeter and the beta HCG level should be less than 5000 micro international units per ml. So here level of 1000, yes, you can give methotrexate. Unruptured ectopic methotrexate. Patient wants to continue, नहीं ऐसा नहीं, continue के लिए surgical नहीं करेंगे. Okay, so continue. This question, this option does not make sense. There's nothing like continue. Okay, yes, very well summarized, Sadia, very good. Okay, and lastly, remember at your level also the 4th point, the fetal cardiac activity should preferably be absent. But most of the question ये mention ही नहीं करते हैं. Okay, so you just remember these 3 things. Yes, कि sir अगर हमारा question paper में even if it is 1, 2, 3 is there, कि sir it's an unruptured ectopic, sac size ये and ये, that is good enough for me. Fetal cardiac activity absent, very good. So that's the same thing. That's the same thing over here. Look at the HCG level. HCG level is only 1500. Patient is stable and it is the size is only 2.5 to 3. So methotrexate. Okay, no need to do repeat and no need to wait and watch. And why to do surgery? Not required. Okay, is it clear to all of you? Just remember, uterus empty and pseudo sac mean the same thing. Pseudo sac happens just because of some hormonal changes. Okay, and we give methotrexate and we give intramuscular route, and then you have to monitor the HCG levels. Okay, HCG should keep on dropping down. Yes, what is this famous picture? This is the mass, and around this mass there's a lot of vascularity. Yes, please understand, very good. Again, this will not be asked to you, but I'm just saying that don't say confirm ectopic. Okay, it is suggestive. It just tells you the ring of fire. This is suggestive of. It is suggestive of a vascular mass. Okay, so it's not a pseudo sac, it is a ring of fire appearance. Okay, ring of fire. Yes, heart disease in pregnancy. MS matlab mitral. Yes, it includes a lot of blood supply and vascularity. Very good. MS is mitral stenosis. Okay, very simple. We have discussed this today only. Yes. Sir, heart disease in pregnancy, propped up position we give, restricted fluids, forceps to cut short second stage of labor when she is fully dilated in station +2, and immediately after baby delivery and placental delivery, there is a 80% increase in the cardiac output. So IV furosemide also becomes very, very important. All of you know Mithergine is absolutely contraindicated. Mithergine is not to be done. Mithergine, I just now told you, heart disease and hypertensive patients, we don't give Mithergine. Okay, because sudden increase in preload, afterload, and heart disease patients can go in, can immediately die. Okay, which of the following heart disease worst prognosis? Very famous MCQ. No. Okay, so ASD, VSD, PDA easily tolerated, कोई problem नहीं है. ASD, VSD, PDA all are easily tolerated, and mitral stenosis also not so much problem. Aortic stenosis slightly more dangerous, but the most dangerous is Eisenmenger's is the answer. Anybody? What is Eisenmenger's syndrome? What is Eisenmenger's syndrome? Eisenmenger's is reversal of shunt. So there is left to right shunt, and there is, yes, very good, Motam. There is development of secondary pulmonary hypertension, and then there will be reversal of shunt, which is your okay, which is secondary pulmonary hypertension, and it has got the worst prognosis. Okay, students, so remember this. And which other condition worst prognosis? Both, even primary pulmonary hypertension. Okay, Arun Chand ulta, right to left. Okay, right to left is Eisenmenger. Okay, so even primary pulmonary hypertension, secondary pulmonary hypertension, and Marfan's with aortic involvement. Again, this has got the worst prognosis. AS after this. Okay, AS is bad, but after this. Okay, yes, Marfan syndrome with aortic involvement. Marfan's with aortic involvement can suddenly during labor the aorta can rupture, and even coarctation with valvular involvement. Okay, so these are very poor prognosis. Yes, very simple. Maximum risk of a heart patient having congestive cardiac failure is when? Directly, most of the students they mark 32 weeks. No, think. 32 is the answer. When? Yes, sir. Immediate postpartum, there is a 80% increase in the cardiac output because of auto transfusion. So immediate postpartum is the answer. If this is not in the option, then you go for intrapartum. If that is also not in the option, then you go for 32 weeks. Okay, is this understood to all of you? Because it is 40 cardiac output rise by 40% during pregnancy, 50% during labor, and immediately postpartum there's a 80% increase in cardiac output. That is the reason why over here we gave IV furosemide after third stage of labor, because there is a 80% increase in cardiac output. There's a chance of heart disease patient going in failure. Okay. Yes. Ideal time to perform the blood sugar screening test. Okay. Whatever may be the screening test given to you, either the DIPSI testing which is done in India or the O'Sullivan test where fasting is not required and we give the 50-gram glucose. In DIPSI we give 75. Yes, 24 to 28 weeks. Very important. Don't make a mistake because that is the time when the insulin resistance is maximum. Okay. Yes, DIPSI test में 75 gram. Correct. What is DIPSI test? Diabetes in Pregnancy Study Group India. I repeat, Diabetes in Pregnancy Study Group India. We are giving 75-gram glucose load. And after 2 hours, we do. Okay, it should always be less than 140. The sugar 140 से कम आना चाहिए. Okay. हाँ. Now, again, first ध्यान से पढ़ेंगे, then decide the answer. So I have got a patient who is diabetes, and at 32 weeks when you do the sonography, the baby is already 4 kilo, baby elephant. Okay, so the point number 1 is at 32 weeks, is this 4 kilo normal or less or more? And previously I have already had a LSCS done. That's why she is gravida 2 para 1 living 1. First delivery by C-section. So previous LSCS. So I have got diabetes. I have got previous all the high risk factors you have to start writing down. I have got diabetes. I have got previous LSCS. I have got big baby macrosomy. Why macrosomy I am saying? Because sir, the baby weight is already 4 kilos. What do I do? Yes. Okay. Now please understand two things. Okay. When we do the scan, correct. When we do the scan, the baby weight is on that day. Okay. Yes. Very good, Bilal. Okay. So when we do the scan, the 4 kilo baby weight, 4 kilo baby weight is at 32 weeks. At 32 weeks on sonography, the baby weight is 4 kilo. When we do the scan, we get the expected weight on that day. So if at 32 weeks the baby weight is 4 kilo, by the time the baby you will reach 37, 38, we will already 4.56 kilo. Yes, baby elephant. Okay. And in previous LSCS, if I want to try labor, big baby, uterus contract, rupture uterus, scar fatega. And for previous LSCS and VBAC, the pelvis should be adequate. So it is no way we are going to induce the labor. This is out of question. We are going to do LSCS only. Now the question is whether 36, 38 or 40. Can anybody tell me why not wait till 40 weeks? You don't wait till 40 weeks because there's a risk of sudden IUFD. Sudden IUFD risk is there, and therefore I never wait till 40 weeks in diabetes. And in diabetes, the rupture will happen in labor mainly. Rupture can happen in labor, and diabetes, the lung maturity is delayed, so 36 weeks is early. There is still a risk of RDS, respiratory distress syndrome risk is there. So in diabetes, remember, you wait more, and between 38 to 39 weeks is when you deliver. Is this understood to all of you? So LSCS at 38 weeks. I just now told you Pre-eclampsia patients, when do we deliver? Pre-eclampsia we deliver 37. Here wait week extra because at 37 weeks in diabetes there is still a chance of RDS. Okay, at 37 weeks RDS can happen in diabetes. Okay, because diabetes में the lung maturity is delayed, थोड़ा सा delayed. Lung maturity is delayed. Okay, is this understood to all of you? So you don't do at 36 weeks, but don't wait till 40, somewhere at around 38, 39 weeks, do the section, get the paper. Very good. Very important. The congenital anomaly specifically associated. Yes. Sir, VSD is the most common, but sacral agenesis, also called as caudal regression syndrome, is the most specific anomaly. Okay, most specific anomaly. Okay, is this understood to all of you? One minute, I'll come back to this again. The most common, again, both types of question. Most common anomaly in the baby of the diabetic mother. So, sacral agenesis is not the most common. It is VSD. That means your cardiovascular system, and then even neural tube defects भी होता है second number पे, but number one is cardiovascular, and in cardiovascular I get VSD more. Okay, is it clear to all of you? Okay, we have got a pregnant lady, mitral valve replacement, MVR मतलब mitral valve replacement, on warfarin. Which of the following is the next line? And she has reached 36 weeks. Very important. It came in the NEET PG, likely to come in FMG also. Very good. So now please understand that whenever the patient is having a metallic valve, okay, metallic valve, we require to give the patient lifelong anticoagulant. Now, when the patient is not pregnant, what do we prefer? Non-pregnant may we prefer warfarin, because warfarin is a tablet, heparin is a injection. Everyday tablet better rather than everyday injection. So non-pregnant I give warfarin, but as soon as the pregnancy happens, till the first trimester, 12 weeks is done, in the first trimester, warfarin is absolutely contraindicated, and therefore I give the patient heparin. Very good. Why? Because Conradi syndrome, Conradi में baby will have central nervous system and cartilage का problem. Okay, vertebral femoral epiphysis, your corpus callosum, cerebellar, all that will get affected. After 12 weeks are over, from 13 to 36 weeks, you can shift the patient back to warfarin. Okay, 13 to 36, we can shift the patient back to warfarin. Okay, and after 36 weeks, which is the question over here, sir, anytime labor can start, and therefore we should stop warfarin because warfarin crosses the placenta, and start heparin. You don't continue warfarin, you don't continue warfarin, because during labor and delivery more bleeding for the mother and baby, and you don't stop warfarin and only start aspirin. Aspirin is very mild. Aspirin is a very mild anticoag. You require more powerful, so you require heparin. Okay, so A is the answer. A is the answer. Basically, you stop the warfarin and start heparin. Is this understood to all of you? Okay, so after 36 weeks, the patient will be on heparin, and after delivery postpartum period, you can give her again warfarin. So don't mug up alternate WH Thokotali. Okay, yes, very good, all of you, excellent. Okay, ha. Now, okay, so all of you students, let's take a small last. So now all these difficult topics MCQ are done. I'll just tell you. We discussed heart disease, preeclampsia, APH ectopic. Just a small 5 minutes break. Just a small 5 minutes break. Last session में मतलब 12:15 to 1:15 1:30 तक we are going to discuss MCQs on polyhydramnios and twins and your preterm labor, that sequence, and then on the Telegram group, all of you had put some 1 or 2 questions regarding that corneal block, and I'll clarify. Okay, so just let's take a small 5 minutes break, a bathroom break, and a 5 minutes break, and when we come back, we continue further. Okay, so just a 5 to 7 minutes. Don't go very far. It's not a very big break. Okay, it's just a small 5 minutes tiny break. Okay, so let us come back in 5 7 minutes and start the MCQ discussion again. Okay. Hello, hello, hello. So can all of you hear me? Can all of you see me? Yes. Okay. So the diagnosis first. What is the diagnosis? Anybody? What is the diagnosis? We have got a patient who is having breach. That is, I think, just to confuse you. And EBW is expected to be that, okay, AFI 35. What's the AFI? Yes, AFI is amniotic fluid index. So the diagnosis is polyhydramnios. Okay, because she is having lot of fluid. AFI is 35 centimeter, and that is the reason why the mother is having also respiratory distress. Is this understood to all of you? So what will I do? Yes. Point number one, magnesium sulfate, no role over here. Similarly, IV furosemide and mannitol is not going to help over here also. Okay. And external cephalic version, no point doing. External cephalic version से breach को आप rotate करोगे, she is only 32 weeks. The purpose ECV will not help in the respiratory distress. Is this clear? Yes. So here we have, and why can't I do ARM? If I do rupture of membranes, that means she will go into labor and she will deliver. We will have to do the delivery. Is this understood to all of you? So external rupture of membranes is done when the pregnancy is more than 37 weeks. If the same patient is more than 37 weeks, then I can plan the delivery because mother is having too much. And you have to be very careful because when you do ARM in a patient of severe poly, okay, risk of abruption, cord prolapse, all that is there. Okay, yes. So here the answer is amniocentesis, which could be done. Anything else can be given. One more drug can be given instead of amniocentesis. So here I poke in the needle, suck the liquor level, suck the fluid out. Any one drug else can be given. Any other drug can be given to control the liquor level. Okay, we can give NSAIDs. Indomethacin, not ACE inhibitors, never beta. ACE inhibitors will cause problem in the fetal kidney. So indomethacin can be given before 34 weeks. Okay, indomethacin at 32 weeks can be given, but indomethacin if you give afterwards, there's a problem. Okay, so before indomethacin can be used before 34 weeks. Okay, yes. Now, 1 second. Uh, this is the one. Anybody that I have got a 36 weeks pregnant lady and indomethacin was given to her for polyhydramnios. What can happen? Simple pharmacology MCQ. Yes, indomethacin will not cause preterm labor and ASD VSD. It is premature closure of the ductus arteriosus, and therefore I never use indomethacin. Indomethacin should only be used before 34 weeks, and that also only if it is a severe polyhydramnios. Okay, if it's a severe poly, then you use it. Okay. Yes. Very good. Now this very simple. Chalo. Again, in which condition The this is very simple MCQ. We are having a patient who is 32 weeks. Okay, and when you do ultrasonogram, all the fetal parameters are corresponding to only 29 weeks. Fetal parameter matlab biparietal diameter, your abdominal circumference, femur length, all are coming lesser. Okay, so this is what this is IUGR basically. Okay, and all can cause this condition except very simple. Chalo. So preeclampsia, yes. Placental infarcts, yes. Some infections, yes. Diabetes, my dear student, is going to cause, yes, big baby, macrosomy. Very good, all of you. Okay. So just by the way, not a very well formed answer, but yes. Okay. So simple MCQ, diabetes. Okay. Diabetes is going to cause big baby. Now this is interesting. Chalo. Okay, actual scenario. Okay, twins डिलीवरी होता है एंड एक बेबी हस्बैंड का दूसरा नेबर का. क्या सिनारियो है? हस्बैंड आस्क फॉर पैटर्निटी टेस्टिंग एंड वन बेबी इज ऑफ हिज एंड वन बेबी इज नॉट ऑफ हिज. तो ये कैसे हो गया? Okay, yes. So please understand that always the confusion is between A and B. You just have to remember one thing: superfetation not possible in humans. What is superfetation? Anybody? It is release of ova while you are pregnant. Okay, two different cycle. That means what am I saying? I'll quickly explain to you why superfetation is not the answer. Superfetation means, sir, one ova is released, one sperm will go and fuse with it, and one pregnancy already starts growing. And now while the lady is pregnant, one more ovulation in the next cycle, and then another baby. So baby ke upar baby. Okay, that is called superfetation. Yes, two different cycle. So that is not possible in humans. Superfecundation is the answer. It is release of two ova. Two ova are released in the same cycle but fertilized by different acts of coitus and by not necessarily the same partner, by different partner also. तभी पता चलेगा. If the same partner, you will not even realize. So what happens? More night, the husband and wife have sex, and the egg and the sperm unite. In the morning, the husband leaves and the neighbor enters, the dangerous neighbor. Okay, and then with the second, this also the fertilization takes place. So it is two ova in the same cycle, but different sperms or different acts. Yes, so but it does it happen nowadays? But very rarely. Okay, but yes, the actual book आप PG textbook आप जब खोलोगे Williams में, तो actual photo is given. One baby, different colors and all. Okay, so yes, so that's okay. One baby, एक baby गोरा, एक baby काला. Okay, yes, crime patrol. Okay, yeah. So basically, superfecundation is the MCQ over here. Okay, two ova in same cycle. Okay, yes. Now moving on. Very simple. Very simple. Okay, what is this famous? Okay, so I'll give you a history. This they will tell you USG of the uterus is there. Ultrasonography uterus. Uterine size. Okay, uterine size is more than the weeks of gestation. Okay, and what is seen is that inside the uterine cavity multiple, ये क्या है? Okay, all this you see, yes, multiple fluid filled grapes like particle. This is the famous snowstorm appearance. Very good, and that is a complete vesicular mole, the famous snowstorm. Okay, snowstorm. The vesicular mole, partial mole mein you will see the baby also. Okay, some fetal parts. So it's a complete mole. Okay, snowstorm appearance. Nothing much to discuss, and HCG levels will be higher side. Okay, yes. Now, what is the management of vesicular mole? Yes, so please understand this, that in vesicular mole, multiple fluid filled grapes like particle inside the uterus. I will never go for induction of labor because it's not a well formed pregnancy. If I make the uterus contract, some grapes come out, some will remain inside. So I never do induction of labor. Never cut open the uterus. Hysterotomy bhi nahi karte hain, and this is wrong. MTP not, this is just to confuse you. Okay, we are 28 weeks uterus size, MTP not allowed. Please understand, vesicular mole does not come under MTP guidelines because it's a defective pregnancy. It is nothing to do with MTP. This is not called MTP. इसको MTP नहीं बोलते हैं. Here under one shot you suck out the pregnancy. So suction evacuation is the treatment irrespective of the size of the uterus. So let the question paper, let the question be okay, let the question be 16 weeks, let it be 18 weeks, let it be 12 weeks, let it be 36 weeks, whatever may be the weeks, the answer will remain the same, suction evacuation. Is this understood to all of you? Whatever may be the weeks of gestation, you suck out the pregnancy, and yes, then you monitor the HCG levels. Okay. Yes. Now this is, many students have a confusion. Okay, sir, patient is pregnant and there is history of delivering a twins in the past. So what is now the obstetric score? So please keep in mind that the previous twins, let it be twins or let it be triplets or let it be quadruplets. Okay, this is all considered as a single pregnancy only. Only the living L G gravida parity living, and if any abortion. Okay, so simple है कि in the first pregnancy it is only P1, one delivery, let it be whatever babies, but sir, she had twins, and if suppose both babies are healthy, so it's called P1 L2. L2 मतलब living babies. So moment you know there's a discrepancy कि sir एक ही delivery हुआ लेकिन दो babies. Okay, and now she becomes pregnant again, so you call her as G2 only. Don't say कि sir first time twins था, so now she'll become G3. So this G3 is wrong, G3 is wrong, and this P2 is wrong. Very good. G2, P1, L2. L2 matlab both babies are living. Okay, is this understood to all of you? So G and P is as per the singleton pregnancy. Of course, L will change. So I'm just giving you an example. Suppose I have a patient is in the first pregnancy. We have, right, so we write G1. In the first pregnancy, she has triplets and she delivers. What will she be called after delivery? Sir, she will be called P1L3. And now suppose second time she will become pregnant, then you call her G2P1L3. G2P1L3 means her second pregnancy, second time pregnant, and first time one delivery, but with three babies, all three living triplets. That is the meaning. Very good. Okay. So G2, P1, L3. Okay. Is it clear to all of you? So don't make a mistake in this. Okay. That is how the things are. Okay. Yes. Again, very simple. Nothing to, but it's a previous year question. Patient is 3 months pregnant. Uterine size is 16 weeks. Uterus more than weeks of gestation. Ultrasonography, snowstorm appearance, not anything but vesicular mole. Okay, very simple. Any confusion? Can we proceed further? Okay, I'll show the picture also. Yes, all of the following are risk factors for polyhydramnios except. So polyhydramnios mainly happens because swallowing. The baby cannot swallow the liquor. Okay, then liquor will be more. Or baby is not is having mother is having diabetes. Okay, so or if there is very rarely choreangioma of the placenta. Choreangioma is a rare condition. It's very rare. It is a placental blood vessel tumor. Okay, chorionic villi blood vessel angioma. Anencephaly is an open neural tube defect. So there will be poly. Why? Because there is transudation. And please, very important, alpha thalassemia is one of the most common causes of fetal hydrops. They will teach you in pediatrics. And in fetal hydrops, there will always be polyhydramnios. Okay, the trick MCQ is a very difficult MCQ. Occult spina bifida is the answer. Why? Because it should be open neural tube defects. What is the meaning of occult? What is the meaning of occult? Occult matlab the skin is covering the defect. So all of you pay attention. Okay, hydrops mein. Okay, this one. Okay, sir. Suppose this is the membranes, and this this is the this, and there is a open neural tube defect when the meninges are exposed. So in a open neural tube defect, the CSF from the baby comes more into the liquor, and therefore liquor level is going to increase in open neural tube defect. Yes, occult matlab hidden. Okay, sir, if the skin, okay, if the skin is covering the defect, if the skin is covering the defect, then the CSF cannot enter. Okay, so in occult spina bifida, please keep in mind, occult spina bifida, there will be no poly. Is this understood to all of you? ऑकल्ट नहीं होना चाहिए ओपन न्यूरल ट्यूब डिफेक्ट में इट इज CSF transudation. Okay, so don't worry, it's a difficult MCQ but a trick MCQ. All of you should get it correct. Okay, just remember alpha thalassemia will cause fetal hydrops, and in fetal hydrops there's water everywhere. There is pleural effusion ascites and there will be poly also. Okay, yes, one of the toughest MCQ which came ever. This is again not a FMG level. This has been asked in the NEET PG. We're expecting it in the FMG in the upcoming years. Basically, if you just remember, okay, RH negative, RH isoimmunization is already there. We've discussed the lecture in detail. Okay, and in the olden techniques, we used to do amniocentesis, and in the amniocentesis, this delta 450 value is in zone 3. Anybody, what does the zone 3 in Lilly's chart explain? So basically in the Lilly's chart, the value can come in zone 1, zone 2, zone 3. Basically zone 3 tells you it is severe hemolysis. Yes, severe hemolysis, and that is the reason why the baby is in hydrops, a baby is in cardiac failure, and basically baby is having severe anemia. So what is our dictum? Okay, sir, if this delta 450 value is in zone 3 and suppose the pregnancy is more than 34 weeks, then it is better to do the delivery. But if the pregnancy is less than 34 weeks, which is the case over here, you can see we are only 28 weeks. Very good, Rohit. Then I do not do the delivery. I do not repeat the amnio. Repeat amnio will be in zone 1, zone 2. And exchange transfusion is done by the pediatrician on the newborn, okay, after baby delivery. So here the answer is intrauterine transfusion. One of the toughest MCQ. I request all of you to go back and see RH ka lecture, but don't worry, I'm explaining in detail anyways. Yes. So if the pregnancy is less than 34 weeks, it is basically intrauterine transfusion to temporarily built up the baby hemoglobin. So the baby will get blood, intrauterine transfusion, baby starts looking better. So zone 3 basically means it is severe hemolysis, and since the pregnancy is less than 34 weeks, intrauterine transfusion is the answer over here. Okay, yes, somebody requested me in the morning, sir, abortion. So threatened abortion का मतलब क्या है? Threatened abortion में there is bleeding, there is spotting, but the good part is that the uterine size is as per the weeks of gestation, where pregnancy can continue to grow. Yes, the os is closed. USG shows a baby heartbeat, that's a good sign, but the os is not open. Question is, threatened abortion is not diagnosed if the os is open. If the os is open, it becomes a inevitable abortion. In inevitable abortion or in incomplete abortion, the os is open. Okay, is this understood to all of you? Okay, so I'll very quickly give you at the end of it, but I'll explain to you one more thing. Yes, so os is open, matlab the game is lost. It is inevitable. So threatened abortion का मतलब क्या है कि sir, there is bleeding, there is spotting, but the pregnancy can continue. Physically, the pregnancy can continue further. Okay, and that is why the heartbeat has to be present, and the uterus will also be growing properly. And yes, but bleeding, spotting is there. Okay. Very good. Risk of abortion, but the baby is still viable, and the os, most important, os is closed. Threatened abortion के लिए the os has to be closed, because if the os is open, the game is lost. Okay. Yes. Now missed abortion. Missed abortion means what? What is missed abortion? Anybody? Bleeding, spotting will be there. But what is the typical thing in missed abortion? Yes. In your missed abortion, the heartbeat is absent, fetal cardiac activity is absent, and that pregnancy cannot continue further. So if the USG is showing fetus with cardiac, it's a good sign. That is a normal thing, right? Normally the heartbeat is present. So in missed abortion, basically the baby, so it's a dead baby, but the baby is not yet expelled out. So there will be slight bleeding can happen. Uterus will be smaller than weeks, and the os is still closed. Okay, so you have to evacuate. What's the treatment for missed abortion? You have to evacuate the uterus. Either give medicines, meso, or you have to give suction evacuation. Okay, either medical management or you do suction evacuation. Okay, is this understood to all of you? So in missed abortion, the heartbeat is absent. That is the meaning. Is this understood to all of you? So threatened abortion, Is this understood? Threatened abortion, the os is closed, pregnancy can continue. Inevitable abortion, nothing can be done. Os is open, pregnancy will come out. Inevitable मतलब होने ही वाला है. An incomplete abortion मतलब the part of the products are out, part are still inside. So even in inevitable abortion and incomplete abortion, you need to evacuate the uterus. Okay, even in incomplete abortion and inevitable, you need to evacuate the uterus. Okay, and the famous RDS dexamethasone dose. Anybody? Very famous. It came even in this INI-CET, likely to be coming in the FMG also. Ruptured abortion कुछ नहीं होता. There's nothing like ruptured abortion. I have never heard the word बेटा. Ruptured abortion जैसा कुछ नहीं होता है. Okay, it is threatened, inevitable, incomplete, complete abortion. Complete abortion में the whole thing comes out. Okay, the whole pregnancy comes out and the os closes, but the uterus will be empty. Okay, uterus empty, os closed, nothing is there inside. It is a complete abortion. And this one, okay. Yes. So now all of you please understand, we should know only one thing. And मेरा trick क्या है कि sir total dose is 24 milligram. Total dose is 24 milligram. What you need to keep in mind. And क्या trick है? Sir, we have got two types of steroids, betamethasone and dexamethasone. Okay. What is the trick? A, B, C, D. Clap if you feel happy. B is the second alphabet, so 2 doses. D is the fourth alphabet, so 4 doses. So अगर आप 24 को 2 से डिवाइड करोगे, 12 मिलीग्राम, 12 मिलीग्राम, 2 doses, 24 hours apart. So 12 milligram, 24 hour apart, 2 doses is the answer for betamethasone. Okay, and dexamethasone, when I divide 24 by 4, I will get 6 milligram, 6 milligram, 6 milligram, 6 milligram, but I give at a gap of only 12 hours. So 6 milligram, 12 hourly, 4 doses. Very good. All of you correct. All of you correct. Okay. We don't give only 2 doses. Dexa का हमेशा है 4 dose. So ये 2 dose out हो गया, 2 dose out हो गया, and 6 milligram will give 24. Okay. So they can ask you anything and all of you will get the answer correct. Okay. Yes. All are causes of abortion in the first trimester except. So diabetes, thyroid, and my luteal phase and chromosomal all can cause miscarriage in the first trimester. Very good. Cervical incompetence will always cause second trimester. And painless. What is the typical history? It is a painless. Suddenly the whole baby comes. A painless mid-trimester abortion. Because as the pregnancy becomes, first trimester, the baby is so small, chintu. Okay, so as the baby becomes big, 14, 16, 18 weeks, it is pressure on the cervix, it will open up. Okay, and the surgery you to do cervical encerclage. Okay, operation. And what is this again? The last one, the difficult, I would say difficult, matlab never asked in FM, but will come. On ultrasonography, which of the following indicates a competent os? Competent. Yes. So all of you pay attention. Okay, sir, when the uterus is like this, Okay, when the uterus is like this, cervix is closed. Okay, so we see a T. Okay, so the T shape is telling me that everything is okay. T tells me everything is okay. Now when the problem will start, as I told you, cervix shortens up before it opens up. So upper part just slightly opens up, upper part slightly opens up, but the lower part is still okay. So this is again the problem has started. इसको बोलते हैं funneling. This is PG level MCQ on ultrasonography. I'm explaining you. Okay, so funneling matlab cervix is not yet opened up, but it is about to open. Upper part is opening already. And then this Y becomes, if the Y part becomes less, then what do we get? We get a shape of letter U. We get a shape of letter U. Okay, is it clear to all of you? So U tells me, sorry, we get a shape of letter V. V tells me that the cervix is just about to open. Okay, cervix is about to open. And finally, when the cervix is already open, the os is already open, the membranes herniate out and you get a shape of letter U. These are the fetal membranes, and then the membranes will rupture. Okay, so you know T will become Y, Y will then become V, and V will then become U. U matlab os is open. So all these are incompetent. The question is, which is a competent one? Sir, T. Is this understood to all of you? T-shaped is considered normal or competent. Okay. Any confusion, any doubts, anything not understood? Okay, so all this what I have discussed are the most important MCQs. Definitely in your exam you are going to get the MCQs of your this threatened abortion, sorry, this one, all these abortions. You're going to get twins, oligopoly, and most important APH, PPH, ectopic and pre-eclampsia. ये चार टॉपिक तो आपको करके ही जाना चाहिए. Pre-eclampsia, eclampsia perfectly fine. Of course APH, of course PPH, of course ectopic, all this, and that trisomy 21. All these are very hot topics. Okay, hot topics. Now all of you, I don't want you to this one get. Okay, so this is what are the list of important. Okay, and of course your this. Now coming to the question paper which somebody had posted the doubt on the Telegram channel. Please understand that if on HSG, okay, I'm solving the doubt of the Telegram. HSG, I see this. What is this called as? Anybody? Suppose I see only this in HSG. हमने डाई डाल दिया and tubes are not seen only. So what is this diagnosis? Anybody? And what do you do next? Very good. So sir, this is on H. Wrong, Rohan, wrong. Suno, ha, IVF never. Okay. First answer correct, second answer wrong. Yes sir, this is a bilateral cornual block. Definitely yes, it could be a block. But please understand, is HSG? No Sahil, wrong. IVF will be wrong. इसलिए मैं सुबह मैं सबके आंसर्स देख रहा था and आप आर्ग्यूमेंट कर रहे थे. I wanted all of you to wait and come in the class. Okay. Now bilateral cornual block हो सकता है, but it could also be a bilateral cornual spasm. What is spasm? Spasm is a temporary smooth muscle contraction. While pushing the die, there could just be a spasm. And please understand this, that HSG cannot differentiate between a block and a spasm. कहने का मतलब ये है कि HSG is the initial test. It is the initial test if there is a problem in the initial test, which confirmatory test do I do? Yes, I need to confirm the blockage. And that is why, please remember, do not directly jump to IVF. I'll tell you when is the IVF the answer. IVF kab answer hoga, I will tell you. Okay, so remember that on HSG, clap if you have learned something new. Bilateral cornual block and bilateral cornual spasm will give you the same picture. Picture will be the same. So always I need to confirm. And yesterday I told you which is the gold standard of the confirmatory test for tubal patency. Okay, we do a laparoscopy and chromopertubation with that methylene blue dye. Yes, laparoscopy chromopertubation first I will do. And sometimes though tube का spasm अपने आप open हो जाता है. And on laparoscopy, you can find out that the tube is actually normal. It can happen. Then the patient will conceive on its own. But picture अभी बाकी है. अगर by chance on laparoscopy also there is a block, still you will first try to remove the block. समझ में आ गया? Try to remove the block. Again PG level है. As a procedure you can do simultaneous hysteroscopy also. So the answer is you do laparoscopy first to confirm whether the block is there or not. And if laparoscopy is showing you a block, it's a PG level MCQ that you will put in a hysteroscope also and try to remove the block. We can try to remove the block. Yes. हाँ तो बेटा you only tell me ना. You only tell me the answer. Okay, you only tell me the answer. Okay, so you will remove the block, but again the thing is question is incomplete. Okay, the question should be infertility bilateral tubal block on HSG. Okay, yes, but you so A is the answer. Okay, beta A. Okay, is it clear, Rohan? A is the answer. We will do laparoscopy simultaneously. We do hysteroscopy also. And in hysteroscopy and laparoscopy, you will try, there's a procedure called as cornual cannulation. You will try to remove the block by doing hysterolaparoscopy. Take home message ये है कि any block on HSG, you need to confirm first by laparoscopy. And since you are anyway doing a laparoscopy, you will also do laparoscopy and you can also do hysteroscopy also, just to evaluate everything. Main is laparoscopy. And here also now suno, here if I can achieve the tubal patency, if tubal patency is possible with HL scopy, of course she will conceive on her own. But अगर आपको क्वेश्चन में दिया है कि सर on HL scopy only, on hysterolaparoscopy there is a block. Hysterolaparoscopy tells you that there is a block and the block cannot be removed. There is a complete, both tubes are blocked and not possible, surgery is not possible to remove the block. Then yes, IVF. Is it 100% crystal clear? I want OG in the chat box if everybody has understood. Okay, is it 100% crystal clear? Okay, sir, the IVF will only be there if we are not able to remove the block. Okay, if the block is there and the block is not able to clear the block, it is persistent block. Okay, if the block is persistent and we are not able to resolve the block, okay, if the block cannot be surgical correction, not possible, then yes, IVF. Okay, so बेटा जो क्वेश्चन है ना, क्वेश्चन वो इनकम्प्लीट है, the previous question कि whether the bilateral block on what. But don't worry, the question is it is a bilateral block on HSG because they just want to make sure. यही trick है कि whether directly you are marking IVF or first you are marking laparoscopy. So this is just to tell you simple HSG initial test, laparoscopy confirmatory test. Basically just confirm first by doing a laparoscopy. Okay, laparoscopy you do, and since you are doing laparoscopy, anyway do hysteroscopy also, and you try to achieve. Okay, and now the second MCQ jo hai, which is forwarded from Arshad 45. Yes, it is a asymptomatic fibroid, isn't it? So just reassurance. Why would you do hysterectomy, myomectomy? Her periods are regular. There is a ultrasound shows a fundal 5 centimeter fibroid. Nothing to be done. I said all fibroids don't require surgery. Okay, there is a fundal 5 centimeter fibroid. You can wait and watch. Why would I do hysterectomy? Why would I do myomectomy? GNA answer is she does not deny any menstrual complaints. Just reassurance and wait and watch. All fibroids don't require treatment. Okay, is this understood to all of you? Asymptomatic 5 centimeter. Just wait and watch. Okay, is this understood to all of you? Yes. Okay, and the last question which was there was regarding the H. But post-menopausal, all the more better, because after menopause the fibroid will shrink. After menopause the fibroid will start shrinking. If there is symptoms, then yes. If they tell you there is having symptoms, post-menopausal bleeding, then you remove it. After menopause, the fibroids will shrink. Okay? Is it clear, Mortem? Got it, all of you? Yes. And the last thing, which was also the question on HRT, which somebody had put in the morning. Okay? We'll clear that also. 1 second. Huh? Yes. Okay. Whenever the patient, see, estrogen plus progesterone. Estrogen is the main hormone required. When you say HRT, estrogen is the main hormone to take care of hot flushes, vaginal dryness. Can anybody tell me why is progesterone added? What is the role of progesterone in HRT? Progesterone is, yes, progesterone is only, बेटा मल्टीपल जेस्टेशन का डिस्कस करें, बट सब कुछ यू कैन गो, वी डिस्कस मल्टीपल जेस्टेशन एमसीक्यूज अबाउट दिस टुडे. हाँ, ओके. प्रोजेस्ट्रॉन इज गिवन in HRT for what? No, what is the role of air? Progesterone is given to prevent endometrial hyperplasia, endometrial cancer. Because if I give only ERT, so therefore we never give only ERT. Only ERT is not given in a lady with uterus. Okay, so if the uterus is present in her body, if the uterus is plus, then I have to give progesterone. बात समझ में आ गया? But sir, when the uterus is removed, that means post hysterectomy, now sir, only ERT is okay. Because the symptoms क्या है उसको, कि she wants HRT for osteoporosis, so only estrogen is the answer. Is this understood to all of you? Can I get 10 thumbs up? Yes. Okay, so just remember that progesterone is added in HRT. Progesterone is added in HRT to prevent endometrial hyperplasia, endometrial cancer, and only HRT can be given because now there is no uterus. So if there's a hysterectomy has already been done, there is no risk of hyperplasia and cancer. Yes or no? Okay. So if the uterus is present, to prevent hyperplasia cancer, you will give progesterone. When in a hysterectomy all done, then you can only give ERT. Is this understood to all of you? So don't make a mistake in that also. And just by the way, of course, if they tell you, then you can also give bisphosphonates can be given, vitamin D, calcium, all that can be given. And just to complete the topic of HRT, It's never ever asked. There's also a drug called as tibolone. Tibolone is a drug which has got all the three properties. Tibolone has got estrogenic property also, progesterogenic property also, it has got androgenic property also. Okay, androgenic to increase the libido. So then tibolone alone can be given because tibolone has got estrogen and progesterone properties both together. Okay, is this understood to all of you? And raloxifene is also a SERM, but it will increase. Okay, raloxifene is a selective estrogen receptor modulator. It's very good for bones, but remember this one very important MCQ. If you get a which okay, which hormone replacement therapy? Estrogen, tibolone, absolute PG level. Don't worry, this question is not going to come. Anybody with the answer? Which hormone replacement therapy can increase the hot flushes? Okay, so main hot flushes is because of estrogen deficiency. And what is the treatment of hot flushes? The treatment is mainly estrogen. So estrogen will not increase the hot flushes. Tibolone, I told you, Rohit, okay, tibolone has got estrogenic property. So tibolone will also help in hot flushes. Raloxifene is the SERM which will increase. Raloxifene ka disadvantage. That's a disadvantage of raloxifene. It will worsen the hot flushes. Okay. Raloxifene is very good for bones. Raloxifene is a SERM, selective estrogen receptor modulator. Okay, so don't worry, HRT menopause MCQs have never come, but just by the way, because the question was there. Okay, so all the three questions we have posted on the group, we have answered it, and don't get confused. Okay, so just read your question correctly. Most of the time you will be getting it perfectly correct, and don't get afraid. Read each and every line and then go for the answers. Okay, so in the last 2 days we have covered everything, and I will just this one explain to you the this one only one more time so that there's no confusion. Okay, and just before that, but which I had said to yesterday also, everybody, so all those you are already aware of, all of you are majority already aware of the whole thing, but please, it is a request. Beta, so you can come on, beta, you can come, Rohit, you come on the Telegram also, join my Telegram. I'll also put it over. Every day I'm putting a quiz. Okay, I'm putting a quiz every day on Instagram also and on my Telegram also. Okay, so I request you, all of you, I will send you. Okay, I'll send you the Telegram ka link because we'll keep this group open, but I'll also, you can join my Telegram channel also. Okay, so all of you are aware, and every day many students are joining the app. And if you want the entire revision of the OBGY of around 15-16 hours in less than in 1 to 2 days time, entire OBGY revision can happen with this app. And there is a rapid revision MCQ discussion package of only 448, and you can please tell all your juniors, yes, you have attended my class, so majority of you are well prepared, but if still one more month is there for entire 1 more month is there for your FMG exam, all of you will do very well. So if you want to just quickly brush the whole obs and gynae, then you can install the app. You can install the app and just go for the rapid revision MCQ discussion videos, and I'll be guiding the students how to study, how to prepare. And please, all of you, this is the YouTube ke liye. Yesterday I put a very fabulous video, everybody is really appreciating that, and I'll also be coming out with some videos on YouTube for FMG also. And please follow on Insta. Every day we are putting quizzes on Insta as well as on the Telegram QR code also. I will put it. I'll send it across in the question paper which I send across to the NLC team. Okay, so Telegram also you can. Yes, very good. Thank you. And yes, baki rest all of you are aware. I don't need to tell you much about the whole thing. Okay, so that is about the this thing, and we had 100% strike rate in the June FMG, June FMG, Jan FMG. Each and every question was for there, and it will come from this only. Okay, so just the last thing, just to quickly complete the whole thing, because all of you, yeah, just 5 more minutes. Okay, so that we have understood the whole thing. Okay, just because there was a this about the this one. Okay, there was a confusion about the this. Okay, so just a second. Yeah, so well, very quickly I'll just last 5 minutes control. Okay, so as I was telling you, in the types of abortion, now you start telling me the answers. Okay, threatened abortion, threatened abortion, inevitable. What is the meaning of inevitable? Inevitable मतलब होने ही वाला है. It is bound to happen. Inevitable. Today the sun will set. Tomorrow morning the sun will arise. All of you will pass FMG. All of you will pass NEET PG. Okay. Inevitable. होने ही वाला है. Then incomplete. Then there is something called as also complete abortion, which I have not discussed. And last is the missed abortion. Okay. Now the whole game, as all of you know, the whole game is on which one? The whole game is on the internal os. Okay, the whole game is on the internal os. Internal os is the most important factor. So in threatened abortion, sir, patient will have bleeding, spotting. So there could be bleeding, there could be spotting, but the internal os is still closed. The process of abortion has started, but it has not reached to a state from where recovery is not possible. I repeat, it has not reached to a state from where recovery is not possible. Matlab basically recovery is possible and the pregnancy can continue. We can have a live birth also. Pregnancy continues if God is great. Okay. So here, can you see the uterus? The uterus will be big. All this in the first trimester, huh? And the baby, tuck, 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 heartbeat will be present. Fetal cardiac activity is very much present, and there is baby inside the uterus. Okay. Yes. Inevitable matlab sir, the os is already open and the products of conception, you will be feeling it on the PV. Incomplete matlab sir, part of the products already started passing clots, but some is still inside. So very good. So in both of this, the os is open. And I told you both of them. So here there could be torrential bleeding and you will see products of conception. Both of this you need to evacuate the uterus. Now what is complete abortion? Sir, she was pregnant. Dhyan se suno. She was pregnant. All the thing came out. सब कुछ complete बाहर आ गया. Spontaneous complete abortion. So finally the os will now close. Yes. Os closed. And no bleeding now. Because everything came out. Now can you tell me? Yes. Can you tell me? First column also os closed. Last point. First column also os closed. Complete abortion also os closed. How will you differentiate? My question is, threatened abortion also the os is closed. And complete abortion also the os is closed. How to differentiate? Simple logic. यस के सर यहाँ पे अभी भी बेबी है, बेबी जिंदा है, बेबी है सर. हियर द यूट्रस इज नाउ एम्प्टी and the uterus size will become smaller. Okay, because sir, she was pregnant, everything came out, os will close, now the uterus is empty. Yes, so heartbeat is present and the baby is bolta hai zinda hu main, that is threatened. Complete mein everything came out, so the uterus will go back to normal size. So uterus will become normal, uterus empty, uterus normal size. And missed abortion, aap log yaad rakho, mini IUFD. See, like IUFD is the word what? IUFD. I tell the student yaad rakho, mini IUFD. Mini, why mini IUFD? Just to remember, mini matlab 6 weeks, 8 weeks. When the baby is dead at 30 weeks, you call IUFD. So actually mini IUFD जैसा कुछ word नहीं है, but just to tell you कि sir, there is either the heartbeat, what happens sir, either the heartbeat starts either the heartbeat starts and then stops, or heartbeat does not start only. So basically the fetal cardiac activity is absent, but the dead baby is still retained inside. Yes, very good, Sadia. Early fetal demise is the word to use. Early fetal demise is the word to use. So you will again evacuate the uterus. So incomplete abortion, inevitable abortion, and missed abortion, you need to evacuate the uterus either by whatever medical means or surgical means. Yes, okay. Is it clear to all of you? Missed abortion. So missed abortion, there might be hardly any symptoms. You just do the scan, you find, oh, baby is dead, heartbeat is not there. There might be no bleeding spotting, but the heartbeat is absent. Os will be closed. Okay, is this understood to all of you? So thank you very much for coming in. Do subscribe to the OG Guru YouTube channel. Fabulous videos are coming out. Please see all the videos on the OG Guru channel, also on my YouTube channel. Insta regularly follow me and you will love it. And also best of luck for all of you, and all those who want to, please tell all your friends and colleagues, and mainly you can tell all your juniors, all those who are going to give the FMG exam in the December. Tell them that these are fabulous OBGY lectures, and I'm sure all of you will say that once you listen to Dr. Punit sir, you will remember. So all those who are planning for the December FMG exam, please tell them to take my just 6 months OG Guru app subscription. And if they are giving next June, then the 1 year you can tell them. Okay. And all of you, if you want a quick revision just in 1 to 2 days time, every day 4 hours karke, in 2 days time, all OBGY obs and gynae revision you can do in the app if you want to. Okay, if you want to. Okay, it's not compulsory, but if you do it, it will be good for you. You will revise all these MCQs and a few others also. Okay, so best of luck. Thank you very much. And I will also put the Telegram Telegram in the group, so all of you can also join on the Telegram, where we are putting daily quizzes also. Okay, bye bye, best of luck. Thank you very much. Yesterday's PDF I've already emailed. Okay, I've already emailed the PDF to the technical team, so they should be giving it to you. Okay, and today PDF also I will send it to the team. Okay, bye bye, best of luck. Thank you very much, and all of you will do very well in the exam is my guarantee. Okay, bye.